welcome to this morning's session, information session to begin with for the Joint Standing Committee on Health and Human Services. This is part of our education process to learn as much as we can about the various bills and issues in front of us. And we've asked the folks today from Tobacco Efforts to come and fill us in on the Tobacco Advisory Council report. So we have a couple people with us who'll be doing that. And before we welcome Deb Dietrich and Ed Miller, why don't we start with introductions? There won't be an opportunity to ask questions at this point. When we take up at 10 the work session, then there will be about the 7 bills that we'll be considering. So let's start with Representative Zager.
Thank you, Mr. Chair. Good morning, everyone. I'm Sam Zager. I represent District 41 in Portland.
Representative Stover.
Good morning. My name is Holly Stover. I represent House District 89, including the towns of Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
Representative Perry.
Good morning. I'm Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Barron, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Representative Craven.
Thank you, Mr. Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Griffin.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cadescate.
And Senator Moore.
Good morning. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Good morning. Thank you, Mr. Chair. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is Elliott, where I live, and parts of Kittery and South Berwick.
And I'm Ned Claxton, honored to represent the folks in Senate District 20, which is Auburn, Minot, Mechanic Falls, and Poland. And saving the best for the last, we can ask Representative Madigan to introduce herself.
Good morning. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
And anybody else I missed? See there, Representative Griffin, you can't take it personally. I know I often miss you, but today I miss Colleen. All right, so we're joined by some folks from the Advisory Council on Tobacco. So I will turn it over to you and I'll defer to you in terms of who goes first.
Great, thank you. Good morning, Senator Claxton, Representative Meyer, and members of the committee. I want to first of all start by thanking you for giving us some of your precious time this morning to give the report, a summary of the report of the Tobacco Prevention Advisory Council. The co-presenter with me today is Deb Dietrich. She is actually the current chair of the group. I am the past chair. I was chair of the group from 2020 and 2021. So it's my honor to be able to be here before you to present our report, a summary of it. Obviously, it will be abbreviated, and we would be happy to come back or answer additional questions. But the council was established as part of the first state tobacco prevention and control program bill that was passed back in 1997. And so the council's been in existence since 1997, but it really was inactive, active early and then inactive for many, many years until it was brought back into existence in 2020. It's a 9-member council. The members are selected by the governor, by the speaker, and by the president. And the function of the council is pretty straightforward. And we really have 2 things that we do. We provide advice to the Tobacco Prevention and Control Program within the Maine CDC and ensure that its work is coordinated with both other state agencies as well as private sector agencies. And then the second role that we have is to look at recommendations, policy recommendations, other recommendations for consideration by the department and by the legislature, specifically to the governor and to the legislature. And those are the 2 major pieces that roles that we play. I want to emphasize that the Advisory Council is not a program evaluation group. Neither is it a management consultant group. Our role is really to look very broadly at what's happening with tobacco within the state of Maine, what the state response and other responses are to it, and make recommendations. Briefly, I just want to highlight who the 9 members are of this group. I mentioned Deb Dietrich, and I'd also say the members of this group, many of us have had experience in tobacco prevention and control, both directly at Maine CDC as well as in the private sector. Deb Dietrich, our chair. We have Deb Hagler, who's a pediatrician. We have Allison Perone Drag, who's with the American Heart Association, Hillary Schneider from the Cancer Society, Cancer Action Network, Lance Bushy from the American Lung Association, Carol Kelly from Pivot Point, and our newest member, we're very pleased to have, is Vicki Wigman, who is the substance use prevention coordinator at Lewiston High School and has been for many years. So we're extremely pleased to have her. One of the things I want to also just emphasize at the beginning is the Tobacco Prevention Control Program has, since its inception, followed the best practices model as developed and established and modified by the National Centers for Disease Control. So this is an evidence-based program that follows national guidance. And so our role is to advise the group on issues of importance, to provide feedback where it is requested, and also to come out with recommendations that we feel are extremely important to be considered. So I'd like to go to I'll hit you with the end of the story first, which are the recommendations from the 2021 report. And there's 6 recommendations, most of which I think, particularly this group, will have some familiarity with. First is to fully fund the Tobacco Prevention Control Program at the CDC, the CDC recommended level of $15.9 million. To create more equitable health outcomes by focusing on populations that are disproportionately targeted and impacted by tobacco use. And we'll talk more about that. To end the sale of all flavored tobacco products in Maine. To resolve the structural deficit in the Fund for Healthy Maine. Significantly increase the price of cigarettes, which is and along with that, because of Maine's law, that would also impact other tobacco products as well. This is one of the most effective tools, as you'll see later, in reducing tobacco use in the state, particularly among young people. And then finally, to not roll back any current policies, whether those be in our smoke-free laws or any other laws that have been passed. So to maintain forward motion and not go backwards. Kind of the overarching message that I want to bring you here today is we are not done with tobacco and nicotine addiction in this state by any means. It remains a significant problem. It remains a cause of concern. It remains a major cause of death, cancer deaths. It costs the state over $800 million a year. It results in tremendous amount of productivity losses due to disabilities and other losses from work. The average household pays almost $1,400 in additional taxes to cover a lot of these expenses. And the tobacco industry continues to spend over $40 million in Maine. And I like to say when I speak to populations that are older than, let's say 30, that if you haven't seen a lot of their advertising, that tells you how smart they are. They're not wasting their money on people like you and I. They are very targeted on how they spend their money. So how are we doing? And this is adult tobacco use in Maine. And obviously we've seen a decline, but we haven't seen the kind of decline that we really need to in this state. Maine's adult tobacco use rate is 16.5%. It's the highest not just in New England, it's the highest in the Northeast. just to give you a little perspective, Massachusetts is at 10.9, Connecticut is at 11.8, Rhode Island 13.5, New Hampshire 13.9. So you get the picture that we have room for improvement here. And it's also important to, when you look at graphs like this, if you dig a little bit deeper, the tobacco problem is not the same throughout the state. We have some counties that are significantly higher than other counties. The two with the highest smoking rates being Piscataquis and Aroostook County, and the one with the lowest rates in Cumberland County. So it follows what we've known for years about smoking rates among it's not just rural, it's lower education, lower socioeconomic status. It's just as I was mentioning, populations that the industry goes after and seeks as customers. One of the other interesting things that the council looked at is this graph right here, which shows the percentage of smokers who smoke within 30 minutes of waking up in the morning. Seems like a kind of an odd thing to to throw out there, but actually what that shows is that we have a group of smokers in this state that are highly addicted. That's what that measure shows, that those folks are more addicted than you might think. I got to interject a little bit of good news, and that is that Maine has one of the highest rates of former smokers in the United States. So that means we're doing our job. Our cessation efforts, our policy efforts are actually working to bring that down. And obviously there's more that we can do, but that is a significant point. Oftentimes we compare ourselves with New Hampshire and Vermont. We're vastly different than New Hampshire and Vermont in terms of socioeconomic status. We're much more likely, as this map shows, to compare ourselves with West Virginia and with Kentucky and even some of the tobacco growing states. So if we look at high school students and what's going on with high school students, and I know this committee in particular is concerned with the young people, 2015 marked really kind of a low point. It was the first time in 20 years when the smoking rate in Maine exceeded the average smoking rate in the country as a whole, and that's not something that we want to see happening. If you look at some of those earlier years in this graph, you can see there were times when we were significantly below. Looking at, for example, 2007. Tobacco tax increase that we had was in 2005, just to point that out. And just like the adult rates, the smoking rates among our youth vary tremendously by county, and they're almost the same counties that we talked about before. Washington County being one of the highest, and York County being one of the lowest. And this is cigarette smoking that we're talking about right here. So the next slide is one that I know there's been a lot of discussion about, and that's just the introduction of vaping products into this whole scene. And this graph basically shows the amount of tobacco use, any type of tobacco, including vaping, and you can see the significant increase that we've seen in that top line in terms of vaping. The e-cigarette use is right now about 1 in 4 of our high school students. But the thing that's very concerning is what's happening in terms of trends. From 2017 to 2019, the overall rate doubled. In Piscataquis County, it increased 4-fold, and Oxford County 3-fold. So just a bit on you'll hear some information about national statistics showing that the rate has dropped precipitously with youth smoking, e-cigarette use in the future. I think that we need to be very careful with that information because due to COVID, the methodology that was used for looking at e-cigarette use from say 2019 to 2021 is vastly different. These studies had been done in schools, and now they were done some in schools, some in home, and it's a real mix. We have additional information that will be coming into you around the e-cigarette use in the state of Maine. But I wanted to just kind of alert you that some of these numbers may seem a bit strange, but even with the rate, if it's dropping down, it is still above the level that in 2018 that the Surgeon General proclaimed to be a national epidemic of e-cigarette use among our youth. So, that's just something to keep in mind. We are not out of this problem in any way, shape, or form. So you are right to be concerned about this. The advent of e-cigarettes and vaping threatens to undo 20 years worth of work that has been done to reduce nicotine addiction among our young people in our population. It's a serious problem. And one of the things that I think is you'll be hearing and have heard about in terms of addressing this is addressing the initiation. How did these kids get started using these products? And there's no question that the use of flavors is the hook that brings these kids in and addicts them to one of the most addictive substances that we know. I will turn this over at this point to my colleague Deb Dietrich to continue I can't see right now because of the screen sharing, but I also want to introduce Ermian Pierre, who is the tobacco program manager for the Tobacco Prevention Control Program at the Maine CDC. She and her staff provide exceptional support to the advisory council. We're a group that meets every month, and that's one more task for her staff to pay attention to. But so we are deeply appreciative to the work that they provide to support us. Deb?
Just, whoops. Sorry about that. Now I'm just trying to unmute myself.
We can hear you, Deb.
Okay, great. Yeah, sorry about that. I have a very touchy mouse, so apologies for that. Thank you, Ed. That was a great introduction. And again, good morning and welcome to be here. So my name is Deb Dietrich. I have actually been on the council since its reinstatement a couple of years ago. Ed, as he mentioned, served as the chair for the first 2 years, and I recently took over just in the past month or so. So we just have a few more slides. I'm going to continue on with the topic of industry targeting. Again, as Ed mentioned, you may not have seen some of these ads that are clearly slanted to both Black and BIPOC populations, teens, et cetera, young adults. Because they don't appear on TV. They appear on social media of all kinds, as well as other activities, be they athletic events, et cetera. So it is a big high stakes marketing campaign that they have been carrying on, and very, very effective as you look at the increasing rates of flavored products, in particular in vaping among young adult populations. So this graph gives a very good historical perspective on how and what kind of funding has been allocated to Maine's tobacco programs over the years since 2000, so a little more than 20 years. And you can see that the green line shows essentially a pretty steady decrease over that time. There have been some upticks in spending for a variety of reasons, but the main message here is that our overall spending on tobacco prevention and control has been declining over this time period. I will point out, Ed mentioned that the recommended level for the state of Maine, from the US CDC in terms of optimal funding for tobacco prevention and control is $15.9 million, so almost 16 million. And you can see that we have varied from that amount pretty consistently over the years. And that, of course, is one of the recommendations that the council is making, and that is to bring us up to that full funding level. The issues of pricing are incredibly important. The price of tobacco products is directly related to the use of those products. There is no question about that. This has been studied over many, many years, lots of publications, et cetera, both the price of the product and, of course, the taxes on these products. And among those populations that are most sensitive to increase in prices, people who have lower income, youth, adolescents, young adults, et cetera, are much more likely to be impacted by price increases. So that is, again, one of the recommendations that we are making. When you look at the data in terms of what impact these price increases and particularly excise tax increases have on the use of cigarettes, you can see back in 1997, the tobacco tax was doubled from an unbelievable 37 cents a pack to 74 cents a pack. In 2000, that's when the tobacco settlement dollars kicked in. The excise tax increased 35%, up to $1 a pack. And then in 2005, which is the last time that Maine increased excise tax on cigarettes and tobacco products, it doubled from $1 a pack to $2 a pack. And the council and other advocates are now recommending and have been recommending for the last couple of years, increasing by another $2 a pack the tax on cigarettes and other tobacco products. And all of those taxes would be automatically equalized across all tobacco products should that excise tax recommendation go into effect. So Ed gave you our kind of list of recommendations at the outset. You are actually going to be hearing a number of bills related to several of these. One, in fact, this afternoon, where you'll see me again testifying on behalf of the council to fully fund the tobacco prevention and control program in the Maine CDC. This issue of equitable health outcomes really couldn't be more important today, as we now have better and will be having better data on the impact among historically disadvantaged populations, particularly racial and ethnic minorities and others, ending the sale of all flavored tobacco products, resolving the structural deficit in the Fund for a Healthy Maine, which I know many of you are quite up to date on, increasing the price of cigarettes, and then protecting current policies, which frankly are to a certain extent always under some sort of assailing by tobacco industry, et cetera. So our objectives as a council for this year are to continue to provide good data. Ed mentioned evidence-based approaches, and that is something that we know what works with regard to tobacco control and prevention. We have been studying it for years. Those studies have refined our knowledge and the data that we have. We simply need to double down on what we know and ensure that we have enough money directed to these activities and evidence-based interventions to see the results. We're going to be working on a new data dashboard as a council to help you as policymakers and ourselves kind of monitor how we are doing in a simple graphic format. We really want to dig deeply into the youth nicotine addiction problem and look at new and potentially innovative, as well as evidence-based strategy options and what resources are needed to address those. We're also obviously supporting the new Maine Tobacco Comprehensive Strategic and Sustainability Plan, which Ermion and her team have produced for a 5-year time period. And then we're also doing outreach to both external partners, policymakers, people across sectors. The report that hopefully you all received at home in the mail has a lot of new data and updated data in it. And hopefully you will, and a lot of great resources. And we are always available to answer any questions, provide any specific data that you might need for your particular region of the state or populations that you're concerned about. So with that, I'm going to end. I understand that there may not be time, as Senator Claxton mentioned, for Q&A, but if you do have questions or concerns, we are always available and would love to hear from you either by email or other communication. So I want to thank you very much for your time and attention this morning.
Thank you for paying attention to the clock, and we do have time for some questions and answers. So I will first go to Representative Meyer.
Thank you, Mr. Chair. Thank you, Deb and Ed, for being here today. It's a dubious distinction that Maine's got the highest youth smoking rates in New England. That is deeply troubling to me. Could you share a couple of examples of how Maine's existing tobacco prevention and control program could increase its impact if it were more adequately funded, ideally fully funded at the $15.9 million that US CDC recommends?
I can jump in and just mention something. Thank you for that question. I'll give you one example, and Deb mentioned it in what the council is looking at in the upcoming year. We have a serious problem with nicotine addiction among our young people, and we do not have the tools to help them get out of that addiction. We are obviously working on prevention, but we have a lot of young people that are addicted now and need help. And it's different help than you provide to a 40-year-old who's been smoking Camels for 25 years. It's a different approach. It's a much more personalized approach, and this needs to be built out, and it takes money. We need to be doing a better job of screening in our schools to identify these problems early. My wife is a high school teacher, and these kids, when she gets them as freshmen, they've already been vaping for 2 years. Many of them. You know, this is something we need to get upstream on. So that's just one quick example, Representative.
Yeah, I would just add to that. I think we do have some of the resources in place. We have a world-class tobacco treatment program in Maine through the Center for Tobacco Independence, and great outcomes from that program. Always, we need to be doing more promotion, more awareness building about the programs that do exist. This is not just a 1-800 number that you call and you get a recorded message. There are trained counselors who work with folks over a period of time. Lots of healthcare providers refer to the QuitLink program, et cetera. But making sure that there is adequate resource allocated to promoting those resources, and as Ed mentioned, developing new resources for populations that really require more innovative approaches is absolutely critical.
Yeah, I just want to add very quickly on this that Maine has one of the best Medicaid tobacco treatment benefits in the United States, and we ought to be proud of that. And we just need to get that utilized as much as possible. So that's another area where, as Deb was saying, outreach, promotion, and helping people through that process.
Right.
Representative Perry?
Thank you. Question on vaping, because my biggest concern as well is in the adult population who, and I have seen it, unfortunately, who get on to the vape thinking that they're going to actually be quitting and can't get off the vaping, and because of the nicotine addiction, and that becomes a long-term issue. Are there means of looking at that and helping people get out from under the nicotine addiction altogether?
Yeah, first of all, let me just say that the jury is out, very much so, in terms of whether or not vaping is a strategy for quitting, an effective strategy. Oftentimes, people who are using vaping as a method of quitting do so on a very short-term basis, but the recidivism is very high. So the research is just not conclusive on that. And I'm sure you have already heard claims that vaping, at least among adults, is really a strategy for quitting. And we need to assure that, vaping products are available to those who want to quit. The other fact of the matter is that most adults who vape are not using flavors. They're using tobacco. They're using tobacco for vaping purposes. So I probably didn't answer your question, as clearly as you might have wanted, but it is, we do know that people who are vaping require similar, if not the same kind of assistance and counseling as people who are using other tobacco products. And we simply need to make sure that the awareness is there for those cessation and treatment programs that are as appropriate for people who are vaping as it is, or they are for people who are using other tobacco products.
Representative Perry, go ahead.
Are there literally smoking cessation programs that actually go through getting down on the tobacco at a level so that they do quit? And if they are, who's following that?
Well, that is the job of nicotine replacement therapy. Most people who quit effectively, whatever method they're using, are using nicotine replacement therapy. It is absolutely one of those evidence-based interventions that when you couple counseling with nicotine replacement, you're going to improve the outcomes dramatically. So that is the medications are a big part of that.
Did that answer your questions, Representative?
Yes. My concern is there's no real follow-up or counseling that goes with the vaping store. And people come in and buy this stuff and then keep going.
Representative, I just anecdotally, I know a number of people who successfully quit using cigarettes and then a number of years later took up vaping. And their story is, this is harder to quit than cigarettes. I've got it in my pocket all the time. I can take a hit off of this thing. Nobody even knows it. I don't smell like a cigarette, blah, blah, blah. It goes on. So it is going to call for some different methodologies to break this addiction. It is still nicotine addiction.
Thank you. I had a request. Can you stop screen sharing so I can see everybody who's here? That's just a structural thing.
There.
Thank you very much. Everybody's back. There we go.
Sorry about that.
No. That's okay. That's okay. My question was about what percentage of states in the country commit to CDC recommendations for anti-tobacco effort at the recommended levels.
To be honest with you, I don't know off the top of my head. I'm sure we can get that information for you pretty quickly. The CDC's recommendations are based on, by the way, a lot of different factors. It's an algorithm that includes a number of different components. Obviously, it's prevention, it's cessation, it's control, policies, et cetera. But we will get that for you. Unless, Ed, you happen to know off the top of your head.
No, my suspicion is that it's not very many based on past history. We have states that have spent very little, if anything, but we can definitely get that. One of the roles of the council is really to look at that CDC best practices, which also includes recommended funding levels for the various program components, like how much we should be spending on counter advertising and media, how much we should be spending on evaluation, and ensuring that that money that we do get to the program is spent in accordance with those recommended guidelines. Because the the best practices are really, they're kind of like a puzzle. The pieces all fit together and they work together. I like to equate it to when you're running your political campaign. If you want to get elected, it's not just the baked bean suppers. It's a whole variety of other things that you put together to get elected, and they need to work together.
Okay, and I also wondered if anybody wanted to offer an opinion on, I think it was New Zealand who outlawed tobacco sales to people under 14, and then every year add a year to that. So that's one of those things for which there
Innovative.
probably isn't real good data yet, and we'll have to wait and see.
Yeah.
It's an intriguing idea.
There was somewhat similar idea in this country of reducing the nicotine content of combustible cigarettes, but that's sort of gone out the window with the advent of vaping.
Okay. Are there any other questions for our guests? Oh, Ed, you mentioned the relationship with CDC and the 5-year plan for Hermione Pierre. Do you want to speak to the relationship with CDC and how that's working for this advisory council?
Just basically, I could say that the federal CDC provides and has provided for decades, really, pretty specific guidance and some financial support to the state program. And Maine has followed those tried and tested interventions to reduce our smoking rate. I've got to say, I almost had to chuckle when Deb mentioned that we've been trying to raise the tobacco tax for the last few years. Well, we've actually been trying to raise it for almost 20 years now, since 2005, unsuccessfully. But that is I can't underscore the value of that. That we have evidence, not just theoretical academic. We have concrete evidence here in Maine of what the impact of that did. And in fact, the last time it was increased, Channel 6 News went out to try to find disgruntled smokers, and what they found were people saying, well, this is going to do it for me. I'm done with smoking. They had a hard time finding people that were ticked off about it, because it's what motivated them to take the next step. And the tobacco quit line at the time saw record-breaking business.
Senator Claxton, let me just add another point to your question about how are we working with the Maine CDC. We're working, I think, very well. I will say that the council, and you probably all know many of the folks that Ed mentioned, we're not a rubber stamp group. We are definitely asking a lot of hard questions and wanting to assure that not only the tobacco prevention and control program is working, but it's adequately funded, and making sure that our role as advocates for some of the things that are needed to make the program as effective as possible are there, both resources, staffing, et cetera. So we're trying to do our job in, kind of minding the store, as it were. And I think we're doing a pretty good job, but we've got a lot of work ahead of us.
Thank you for that additional information. I think too, at some point, maybe not this morning, the committee would like your thoughts about how to avoid having to reconstitute the council at some point in the future. And we'd be interested in hearing your ideas about that. Are there any other questions for our guests, Deborah Dietrich and Ed Miller? Beyond my thank you for your ongoing efforts for decades in some cases, and for eons in others.
That would be true for Ed and I think, combined. Yeah.
I was there when the cigarette was invented. I told somebody I've been defending the Fund for Healthy Maine since I had hair.
Well, thank you both for being here, and
Thank you.
I'll be interested to get that information. If you get that to Sam or Anna about the percentage of states that are compliant with CDC funding recommendations, that'd be helpful. Okay, well, thank you again for being here.
Thank you.
Thank you all very much.
Have a good day.
You too. Thanks.
So we'll be going to consideration first of LD 1701 and.
Senator?
Yes.
I'm sorry to interrupt. If we were sitting around the horseshoe, I would elbow you. But Sam, I believe, had a little bit of work for us to do before we launched into the two
Okay.
work sessions.
Okay. And I was going to give Representative Lemelin a chance to introduce himself.
Thank you, Senator. I'm Michael Lemlin. I represent House District 88, Chelsea, Jefferson, Whitefield, and Half Nobleboro.
And Senator Baldacci.
Joe Baldacci, I represent Bangor and the town of Herman in Senate District 9. Thanks.
Representative Javner.
Good morning, everyone. I'm Kathy Javner, and I represent House District 141, which is located in Penobscot and Washington counties.
Did I miss anybody on the first pass who's since joined us? Okay, then we'll go to Sam before we begin considerations of the bills for our work session. And feel free to interrupt me anytime.
Thank you, Senator. So I just have one language review for the committee. This is the minority report for LD 867. I'm going to put it up on the screen here. So if folks will recall, this bill was voted on by committee. The minority report voted and ought not, or the majority voted ought not to pass. The minority voted ought to pass as amended, and this is that amendment. And folks who did vote in favor of the amendment have seen this. I think the rest of you have not, and I will send it out after this. So the amendment changes the title. It strikes this reference to the 5 years to allow for safety testing and investigations, and instead inserts state to make it clear that the intent is to prohibit mandatory COVID-19 vaccinations by the state. The preamble has been changed a little bit. There's some language here. When you see language like this that is a little bit wordy, it is often what we call a preamble that is intended to guard against constitutional challenges. So that verbiage there is intended thus. In section 1, the language referencing again the 5-year limit to allow for safety testing into reproductive harm has been struck, and instead a general moratorium on mandatory COVID vaccinations has been inserted, and that would apply to any resident of the state. There's some cross references here. So they include some language in title 20A, which is the education statute, and that language is in there because the education title has a bunch of very specific references to immunization. So just putting the language in Title 22 wasn't clear if that would be sufficient to cover students as well. So there are references, a couple references throughout Title 20A to make it clear that mandatory immunizations against COVID-19 would also not be allowed for students. And there is also here, this is a bit esoteric, but this is in Title 26. There's some language that has to do with state employees and immunizations and other requirements for state employees. So there's language in there to make it clear that prohibition against mandatory vaccination applies to state employees. So in sum, the intent of this amendment is to prohibit mandatory COVID vaccinations for all state residents, and the language there has been changed to make that clear. I'm happy to answer any questions.
Senator Moore, are you comfortable with that minority report?
Yes, Senator Claxton, I was going to raise my hand in just a second, Terry. I am very comfortable with it. I have run it by the sponsor. Representative Quint, as well as my caucus, and we all are in agreement with the amended for the minority report.
Very good. Thank you, Sam. And I note that we've been joined by, well, I should give Sam a chance to introduce himself since he didn't do that first pass, I don't think.
Sam Seneff, legislative analyst with the Office of Policy and Legal Analysis.
And I see that Anna Broom has joined us.
Hi, I'm Anna Broom. I'm the other legislative analyst in the nonpartisan Office of Policy and Legal Analysis.
And we didn't give Karen Thomas a chance to introduce herself.
Hi, I'm Karen Thomas, the clerk for the HHS committee. Please email me at hhs@legislature.maine.gov should you need anything. Thank you.
Thank you for that. So now with permission of my co-chair, we'll go to consideration of 1701 and then 1608. Then we'll touch on 1864, 1865, 1761, 1849, and we'll save 632 for the last. Okay, so I will turn it over to you. Are you ready, Anna? On well, we're starting with 1701, so there wouldn't be a presentation about that. This is the bill that would establish a managed care program for Maine Care Services. We did get a letter with some links to from NCSL that provided some additional information. So thank you for those. So any thoughts about LD 1701 at this point? Well, it's remarkably quiet from this committee. Yes, Senator Moore.
Yes, Senator Claxton, I believe one of the things we asked for was maybe a mapping from Maine Care as to what the plans were for the next, 5 years, I think, or something. There was one of the requests that we had made. And I didn't know if we have that available, if I missed it or what was.
Yes, it's available, and we're bringing Director Probert in, and Molly's already here.
Awesome. Thank you.
Thanks. And if we could bring Olivia Alford in as well, that would be great. I think there are two of her because of some computer issues, but if we could bring both in, that would be wonderful.
We had the other day it was a record. We had 6 in one instance of the same name. So thank you for that, Senator Moore. And so we'll defer to Director Probert. Welcome.
Thank you. Okay, great. And I see Olivia Alford has come out of the wormhole as well, so that's good.
Both of her.
Both of her. She's very efficient, and that's partly why, because there's 2 of her, which I love. Good morning, Senator Claxton, Representative Meyer, and members of the committee. We actually do have a presentation for you in response to your request to get a better idea of the roadmap that Maine Care has in regards to our efforts to ensure high value care for our members. I will share my screen and Olivia and I will be partnering in this presentation this morning. So give me a moment. So first, I should say, my name is Michelle Probert. I am the director for the Office of Maine Care Services. And Olivia, could you introduce yourself as well?
Sure. Good morning. It's Olivia Alford. I'm the director of the Delivery System Reform Unit within Maine Care.
Trying to get you to the correct view here. Okay, do you see the big slide and not the weird black screen? Yes, excellent. All right.
Hang on just a minute. I want to give Representative Millett a chance to introduce himself if he'd like to. Welcome, sir.
Thank you, Senator. Someone Millet, House District 71, Towns of Norway, Sweden, Waterford and West Paris.
and the sponsor of the bill. Thank you, Director Probert. The floor is yours.
Great, thank you. So Olivia and I were here a couple of weeks ago speaking to you about Maine Care's knowledge of managed care. We shared very briefly that the intention of managed care, broadly speaking, is to improve cost and access and quality. We shared that the results have been mixed on those fronts across the country, but that some findings are that that having sufficient time and resources for extensive stakeholder engagement, very careful procurement, and aggressive contract oversight are all really important components if a state does proceed with managed care. We also, in summary, shared that whether or not states engage in managed care, there is a strong consensus that transitioning to alternative payment models that move away from paying just on the basis of volume and tying payment to cost and quality is really key, and focusing on broader delivery system reform is also key. So on that front, our intent today is to go into more detail on our current initiatives and plans and timelines around moving our delivery system towards the provision of higher value care. We will also make brief mention of certain initiatives regarding improving the efficient administration of the Maine Care program as a whole. I did just want to share that Maine Care has identified 4 strategic priorities. We most recently updated these priorities in May 2021. I'm not going to read all 4 of them, but you will see the first 2 bullets really relate directly to what I just said this presentation is about. So, we truly do see a transition towards high value care, as well as the strengthening of our internal systems as being key to the work that we are doing within the Maine Care program. And with that, I'm going to hand things over to Olivia, to our Director of Delivery System Reform in the Office of Maine Care Services. And I will join for the last few slides again at the end, but don't kick me out, I'll still be here.
Thanks, Michelle. So something that I often get asked, and I think is really relevant to cover first here, is what are we even talking about when we say delivery system reform? The language around this has evolved over time. And one of the best depictions of this actually was just released from CMS last fall in their innovation strategy refresh. And so I've been using this as a really great point to illustrate that delivery system reform is about a lot of different things. It's not really just one, it's not just changing the way we pay for services. It's also thinking about all these other concepts that feed into how that's going to work out in the real world. So what are we trying to do with delivery system reform? We're driving accountable care. That's where in the past, you may have heard my unit and many other conversations really focus on value-based payments or value-based purchasing. Value-based purchasing is a mechanism to drive payment reform or to drive delivery system reform. It's the ways that we align incentives, that we put financial elements at risk or at reward in order to move the market. So driving accountable care is where we really get the concept of value-based purchasing as part of what delivery system reform is. Really key, delivery system reform is now recognized as a way to advance health equity, support innovation and flexibility for providers. It's intended to be a partnership with providers. It addresses affordability. Again, there's many instances where it's proven to reduce costs and improve quality. And CMS is very committed to driving forward that from a federal perspective, and Maine Care is really focused on the cost component of this as well as part of the equation, is how do you get to higher value services. And then as I mentioned before, partnership is critical to delivery system reform, and Maine, I think, is just really a leader in this. We have really strong partnerships with our health systems. We work directly with them on a daily basis. We work across the department and across state agencies. We work with you all. I think Maine is really has been in the past and continues to be an example of how partnership can really be used locally to make solutions that work in Maine to drive delivery system reform. And it's one of my favorite parts of my job for sure. So this is not we borrowed this framework, but I think it really helps drive the main points home. So next we'll go to another framework that really helps us in our work. And you've seen this before from us. But when we talk about alternative payment models, we're getting to that point of what's the payment mechanism that supports provider flexibility, innovation, partnerships, supports advancing health equity, and drives this reform. So you heard that we have a set of goal to have 40% of main care payments tied to value or in alternative payment models by the end of this year. We have made great progress in that, and this is a tool that we are able to share with the public on an annual basis or more frequently if requested, to show and demonstrate that main care is making progress towards delivery system reform. Now, it's very important to say that changing the way you pay for services is not sufficient. Changing the payment model is not the goal in and of itself. It's the mechanism to get to the desired policy outcome. So in addition to measuring how many payments or how much of our payments are tied to value, we also look at, are we driving the policy outcomes that we want to see through those payment incentives? So it's a multifaceted question, as the previous slide got to. So we have this formalized method for ongoing measurement, and we have a formalized framework that is used across the nation to advance accountability within those contracting lines of alternative payment models. We feel very solid about this work and this framework. And the next slide is our key principles for delivery system reform. And what I'm trying to illustrate here is that, when we do this work, we're really talking about doing a lot of comprehensive evaluation on what's going to make this, again, reach the desired outcome. So we are very committed to engaging stakeholders early and often. We learn from national experience and local experience to see what will work in Maine. Part of it is really looking not just at Medicaid and directly what is the service rates, what are the service requirements, what is the authorizations and team members, all those things that certainly go into the Maine Care Benefits Manual, as you're well aware. It's also looking at what tools are needed in the infrastructure around the healthcare community. What data do they need access to? What can we provide for investment in health information technology to support them in doing the work that they want to do and that we want them to do? What can we change in broader context and culture around the work to support them? And then this next one, aligning efforts across DHHS and other payers. Oh, sorry. As you know, DHHS is doing a lot of work right now. There's Fast and Furious doing a lot of great work. And so we have really paid attention to making sure we're aligning efforts within our office, within our department, but also with payment opportunities and multi-payer projects nationwide. And we, again, focusing on health disparities, we'll get into that a little bit. And we are aligned with CMS in that sometimes these changes need to be incremental and they need to be very well planned. So we have glide paths and multi-year stages at which we hope to get to some longer term goals. For today, and this is a brief presentation, I know I'm going fast, but what we wanted to do was just highlight how these principles play into one of our largest initiatives or our largest initiative, and just lay out how that kind of looks within a program. So the Accountable Communities Program, you may be more familiar with this term as an accountable care organization. Maine Care has had this program in operation for over 8 years. We were one of the initial Medicaid agencies to develop an accountable care organization within our program. And it has grown to now include over 115,000 Maine Care lives under accountability of this model. The model essentially puts an entity, the Accountable Care Organization, in a position where they are accountable for the cost and quality of the attributed members for their AC. They are able to generate an opportunity to have a shared savings payment which indicates that if they come in below projected cost expectations and achieve a standard of quality, then they're able to share back in some of those dollars that was saved to the state and to the federal government. It's a very critical part of our model, and something I'll want to come back to later is that the way that the Accountable Communities program is really centered is around usual sources of care or primary care. Where does someone go for primary care? And that leads to how they become part of this program. So primary care is the critical infrastructural component to the AC program. We have, next slide. We have a number of goals related to the AC program that we have made great progress on and that we want to share with you. And they really get to the key principles. So first bullet here, we have wanted to increase the breadth of services that are covered under the Accountable Communities, their accountability structure. It's already quite comprehensive with behavioral health, pharmacy, medical services, durable medical equipment, things that you might expect. But just this past summer, we even increased that a bit more by including additional behavioral health services that had previously been left out. Some of our newer models, opioid health homes, behavioral health homes, some residential services. And so really making sure that behavioral health is fully integrated within the AC structure. What that does, and what we have seen, is it really starts to build partnerships across agencies that are not connected from an ownership perspective necessarily. So you have, let's just use large entities like Maine Health or Northern Light, Maine General, Community Care Partnerships of Maine. They are able to say, okay, I need to reach out and partner with these other providers who are not part of my network. Again, they're not part of our system, but we need to collaborate together to try to reduce the total cost of care and achieve the quality outcomes. It's, again, a financial mechanism to build those partnerships. We are committed to moving to a shared risk model next summer, which that means is actually it's a more advanced alternative payment model structure where these entities become responsible for poor performance as well. Or in other words, if they do not succeed in achieving the cost neutrality or cost savings that they sought to achieve, they will actually owe money back to the state. Because we are investing in this program, we have been for 8 years, and we want them to be accountable for the success. It's a way to share risk and accountability from the state with our provider partners. We have implemented a number of contractual obligations around addressing social health needs. This is a best practice that is seen nationally across ACOs, and something that we received some specific guidance on through consultation with a national vendor 2 years ago in implementing this program. We look to grow the AC program, which has happened every year, and that's an important piece, again, to make sure that the reach of this program extends to more Maine Care members so that they have that level of population health oversight covering them from a coordination perspective. And then we continue to partner with ACs, community-based organizations, other providers to connect the dots and provide the health information technology infrastructure, the data supports that help them do this work and innovate in their own right to drive outcomes. Next slide. Thank you. So I said I was going to come back to primary care, and we have this long list here on other delivery system reform initiatives that are planned for the short term. You may or may not be familiar with these models, and I don't think we'll have time to go through every single model here, but all of these will represent alternative payment models. All of them will be tied to performance that are reflective, performance metrics that are reflective of the goals of that individual program or service or policy. Something, again, to tie back to primary care, which takes planning and deliberate conversations, is that we've embedded this link to primary care as a really foundational piece of how a health system operates, and what a healthy health system provides is access to a usual source of care or primary care. So we've tied that incentive across many of these programs so that we have providers across the care continuum, across organizations and entities working towards a common goal that will lead to the outcome that we seek to achieve as the state. So you have hospitals being held accountable or being incentivized to have primary care access for their community. You have opioid health homes who serve members with opioid use disorder being scored on how many of their members have seen a primary care provider. Similarly with Primary Care Plus, clearly a primary care focused initiative. And just to mention one more, the Certified Community Behavioral Health Clinic model it's a behavioral health model that you may have heard about, which we won't talk in detail today, but it's truly about both comprehensive behavioral health access, but also the integration of behavioral and physical health care, including access to primary care. So it's really about designing these systems that work together and then measuring our progress over time, which we will be doing and happy to update you on as we continue with the work. And then I'm going to hand it back to Michelle, I think, for a few more slides on other efforts. Oh, you're on mute.
Of course. Thanks, Olivia. I will be brief. You all heard from me yesterday about LD 1867, our main care rate system reform bill. I'll just quickly mention that we see this as very critical to both ensuring that we have an adequate provider network to make sure members have access to care, and that also part of the bill ensures that we review services so that we can continue our progress with moving towards alternative payment models. So I wanted to briefly touch on a few of our administrative efforts. One thing to note is that for our members who are enrolled in both main care and Medicaid, we have strengthened the department's contract with Medicare Advantage dual eligible special need plans, a mouthful, also known as DSNPs. And as part of our work with 9817 of the American Rescue Plan for home and community-based services, we are going to be engaging with a vendor to help us develop a strategy about how DHHS, so that includes main care as well as the Office of Aging and Disability Services, can better manage care and costs for this dual eligible population so we can continue to make progress there. I also wanted to briefly mention some of our pharmacy initiatives or aspects of our program. One is that we have a model that is a pharmacy benefits administrator model. This is more and more considered a best practice. So it's a transparent model where our administrator, Change Healthcare, passes through all the rebates and the drug discounts directly to the state. So there's no fear of hidden costs or fees that you often hear about with PBM models. The state is also an active decision maker when it comes to administrating our pharmacy benefit. That includes establishing state maximum allowable costs. You may not be aware that we're also in a collaborative with 13 other states, state Medicaid agencies. We work with those 13 other states, which cover 10 million Medicaid member lives, to negotiate for enhanced rebates on drug costs above the standard Medicaid rebates. So that is a powerful partnership for us to save dollars for the state as well. And then lastly, preferred drug lists are very common across all carriers in Medicaid and Medicare in order to manage pharmacy benefits in a clinically appropriate as well as cost-effective way. As I'm sure many of you are aware, many of the high-cost specialty drugs are now going through the medical benefit, so they're physician administered. We are in the process of implementing a preferred drug list for physician-administered biosimilar drugs. And this will allow us that when you have an equivalent medication, that one of them has preferred pricing, and again, is clinically equivalent, then we will drive members towards that more preferentially priced clinically equivalent drug. Briefly, I wanted to give a shout out to broader department efforts for access to coverage in addition to our rate system reform effort. As everyone is aware, DHHS has created the Office of the Health Insurance Marketplace, and we're so excited to work with Director Garrett Reed, as we have been having that office within DHHS to collaborate with Maine Care is very important, and especially when the public health emergency ends and we will see Maine Care members needing to transition from Maine Care. It's great to have a home for those individuals to go to continue their coverage. Our sister office, the Office for Family Independence, which is responsible for eligibility and enrollment for Maine Care, has been doing a lot of work to improve their eligibility systems and the friendliness of those systems for members to be able to use. So we really look forward to those improvements, and we are continuing our ongoing monitoring as well as evaluation of our Maine Care expansion efforts. And then lastly, I also wanted to talk a little bit about our Medicaid enterprise system. That is a CMS term. It's basically our claims system. It's how, but it's broader than that. And it's how we make sure we have the appropriate systems to administer the health plan that is Maine Care, essentially. So Gainwell is our vendor for our biggest piece of that system. I wanted to brag a little bit that we've had a lot of focus over the past couple of years in our provider enrollment system. There had historically been a lot of challenges with that system. As an example of how we have achieved significant improvements, between January 2020 and January 2022, we went from having over 1,000 enrollment cases pending to 150 enrollment cases pending. So we have made huge progress in terms of the timeliness with which we're able to get through those enrollment cases. And then also from on a related front, between January 2020 and January 2022, it used to take us 88 days on average to complete a provider enrollment case, and now it only takes us 20 days. So we are really proud of our team for those impressive improvements. We are focusing on technology changes that align with those strategic priorities I shared with you earlier and our program needs. That includes streamlining our federal reporting and also making it easier for us to implement delivery system reform initiatives, because many claim systems are set up to pay fee for service, and it can be challenging and time intensive to change those systems. And then lastly, we are working right now on a common vision of how Maine Care's health IT investment operate in concert with a larger health system and statewide efforts. Every state has to do a state Medicaid health plan, which looks at health IT. And we are working on that right now and plan to be completed in spring of 2022. So that is our overview of our efforts. We thank you for your time this morning and hope that that was helpful.
So does this bring up any questions from the committee based on that presentation? Thank you, Director Probert and Olivia Alford. Yes, Representative Perry.
Thank you. You did mention population base and population health. When you're determining payments and moving forward, how much of a track do you keep of population health in the areas of the state, and how that should look with Maine Care?
So I think I missed part of what you were saying, cut out a bit, but essentially for how we track population health was the question across our populations. Yeah. So we have a number of ways that we track population health. We have internal reports were generated that we look at major utilization, chronic disease burden, trends across our whole population. We also have a very, actually a growing analytics tool that's connected to the Health Information Exchange that allows us to look at predictive risk across our population and utilization. But maybe to more get to your question, within some of these programs, I'll take the accountable communities to keep on that thread, we issue trimesterally and annual, so regular reports to providers that give them insight at a population health level into some of the major metrics and quality measures around their population. So they have access to that data on a regular basis. We also actually provide these entities with full claims history through a contract with them so that they can do their own analytics. And we've seen great growth in our AC partners and how they've been able to, in their own systems, utilize the information we are providing for them to do to design interventions for their own populations and use it. And what we're looking to see in the future is for them to communicate back to us, visions and plans on how they're doing that. What support do they need from us? How can we work together to drive the outcomes using all the information that we have available amongst ourselves?
Thank you.
Representative Craven?
Thank you, Mr. Chair. Thank you for the presentation. My question is really just like a global question. For example, how disruptive would it be to the work that you're doing if there was a managed care organization inserted into main care, or even managed care for certain populations?
I will say honestly that the process of inserting that managed care organization is very disruptive because it is, when a state implements managed care, it is so important for that to be the ultimate focus, not of just the state Medicaid agency, but really of the whole department. And so all of our other initiatives by nature would need to take a back seat. I first joined Main Care when the Office of Main Care Services was in the process of implementing managed care. And it was the initiative that everybody was working on. And it also means an entire reorganization of the office to transition from being the health plan ourselves to really being an entity that is prepared to do aggressive contract oversight, which is a different workforce, to be honest with you. So if we were to transition to managed care, we would absolutely want to continue to prioritize the initiatives that Olivia was just speaking to you all about in terms of delivery system reform, and those would continue, but progress may certainly slow down because in order to do managed care well, it really needs to be all hands on deck. It is not a fast process. It takes at least a couple of years and oftentimes longer for states to successfully implement.
Does that answer your questions, Representative Craven?
Yes, thank you very much.
Representative Millet, in the normal or the more typical course events, we'd have an analyst report to respond to, but since it's been a year, March, since the last hearing, this is as close as we're going to come to that. But I wondered if Representative Millet had any feedback or any response or any questions based on what we just heard.
Well, thank you, Senator. First and foremost, I want to express my appreciation for the work that this committee does. I think your committee, combined with the two that I serve on, probably have more responsibility for dealing with complex issues and trying to sell our products to the entire legislature than any others. I'm thinking about the relationships that we have in appropriations and on the Government Oversight Committee with DHHS, which I know is not only the largest, but probably the most challenged department in all of state government. And within the new administration, I say this with respect for the governor and the commissioner, I've gone out of my way to try to put my faith in the people that I trust the most. And I always hold them up as good state employees. I want to see them succeed. And I'm really at a point where I am trying to measure performance against rhetoric. And frankly, I'm hearing a lot of rhetoric, and I'm concerned about the attempt to say we're doing all of these great things, And it would be disruptive to try something that is working in 40 states. So I'm a little disappointed. I'm aware of the fact that this was a late submitted bill, and clearly, and you've been very helpful to me, Senator, so don't take this as criticism. You've gone out of your way to give it full consideration. I would say that my people that have advanced the bill to me for consideration had hoped for an outcome that would at least give us a chance to do some paralleling with selective managed care populations even on a voluntary basis. That appears not to be within the framework of the department's vision for what they're doing right now. So I'm not going to try to lobby you folks. I know what you're up against. I do think that there is merit in the managed care concept. I worked with the idea in previous roles, including my role and time at mental health, mental retardation, and substance abuse services in the King administration and in other ways. And I still see merit in the idea, as do other states. So I guess I will continue to examine, in my view, whether the words match the performance for this very complex department.
Thank you for your comments. Senator Moore, you had your hand up. Did you have a comment or question?
I have a comment. This is such a huge policy decision that we have to make. And I really respect Representative Millett and all of his hard work. I'm just very concerned about us trying to throw this into the mixture itself. With what's going on right now. I know that we've been talking about managed care for years. I know that we've been asking for lots of main care revisions, but I think we're finally to the point where we are seeing some things happening. And, by looking at it, and I think it's our responsibility as a committee to hold the department responsible to do what they say that they're going to be doing. I'm just so hesitant about this, going into this managed care at this point in time.
Representative Javner, you had your hand up.
Yes, thank you very much, Senator Claxton. I just really want to echo Representative Millett, and he has such a much longer history with the department than even I do. I've been 3 short years in the depths of the department and what's been going on. I really just want to ask Director Probert. It's interesting because I was thinking about that this concept that Representative Millett brought up, even of having, selective populations be sort of, like a pilot project, be put into a managed care program. I was thinking about that this morning, what that would look like. I wonder if if Director Probert could speak to that just a little bit on the efforts that perhaps could be put forward towards that.
Just to make sure I'm understanding your question correctly, Representative Javner, so are you asking if there would be a way to do a pilot of managed care? Is that the question?
I guess I'm utilizing the word pilot simply because I don't know another term to use for that. So it's, we know Representative Millett said a selective populations that utilize main care. And in my mind, that's a pilot where we would pull out a couple slices of the pie, so to speak, and put that in towards managed care. I do agree with Senator Moore. It is a massive undertaking. I don't think anybody on this committee or the sponsor of the bill or anybody in our legislature at this point or this administration would think that it's not a huge issue. And again, just, so that's, that slice of, a piece of the population that's serviced.
Sure. Thank you for the clarification. I will mention a couple of ideas. One is that in discussions that I believe this committee has had around dental care, there has been discussion about implementation of managed care for dental services. When the department was discussing that possibility, we agreed that there may be many benefits to that, including the fact that we had heard from dental providers that they are really much more used to dealing with dental health plans, and that if Maine Care were to partner with a plan to administer the program, it would be a lot easier for them to serve Maine Care members, and we have the goal of expanding access. The reason why we were not able to implement a transit or integrate a transition to dental managed care as part of our adult dental benefit that we'll be expanding to this July is just that is 1 year in order to implement that was not going to be sufficient. But I think that I speak for the department when I say that we would be very willing to have more conversations about that, because I think there are real benefits. I also mentioned briefly the work we've been doing with the DSNP health plans and the fact that we are bringing on a vendor to have the conversation, which will include looking at integrated managed care for individuals who are on Medicare as well as Medicaid. Because when you think about those individuals, they're having to deal with 2 different entities to get their care. And it is hard to have an integrated program and to have providers have to deal with those different health plans as well. And so in our conversations with the Office of Aging and Disability Services, we're also interested in exploring that population because when you have to deal with 2 plans as a single person, and when providers have to deal with this, it just gets more confusing. So we are interested in specifically bringing on a vendor to have more of those conversations on that front as well. So when I think about kind of trying out managed care, those are the 2 examples that first come to my mind. I think that, you know, if you're thinking about any other populations, then you have to consider that, for example, if you had behavioral health in managed care, then anybody who had behavioral health needs, which is most of us at some point or another in our lives, again, would have to kind of manage both receiving Maine Care non-behavioral health Maine Care benefits through the Office of Maine Care Services, and then having a separate health plan that they deal with for all their other behavioral health. And so that makes our goals around integrating behavioral and physical health care kind of more challenging. Olivia, I don't know if you would offer any other thoughts on how to kind of try out this concept in a smaller way.
You know, I think it's just like being open to additional conversations about how managed care companies, and when we say that term nationally, that doesn't always even mean Aetna, Anthem. It doesn't always mean those entities. In other states, entities have risen up and been created through planning, you know, multi-year planning, to become essentially a similar type partner with the state around ACO initiatives, for example. And there's different ways to change those models into capitated risk models and other options that can include what you might traditionally think of as managed care, but can also include more locally driven organizations that step up and say, I want to do this work. And so there's different ways to think about the functionality of what your managed care partner provides from an administrative perspective or a payment perspective, risk perspective, and then just thinking about the different opportunities and who can come on board with that. So I think we always look to those examples and see what might be able to be brought to Maine. But I think the 2 things that Michelle highlighted are probably the most consistent things to look at first that would fit in with the current work, and also just with potentially the way that Maine people experience their healthcare.
Great, thank you. I think that the dental providing, I think that actually is probably a great place to start at. And I'm not sure what it would do, what we need to do in order to keep those conversations going, Dr. Probert, but I'm very encouraged to hear that.
Happy to speak more.
Representative Meyer.
Thank you, Mr. Chair. And thank you to the bill sponsor for bringing it forward. I think it's certainly given this committee an awful lot to think about. There's been a lot of discussion. I feel that the department is clearly making progress towards delivery system reform, driving accountable care. It's a staged approach they are clearly in the midst of. Things don't happen as quickly or exactly as we might wish them to, but I believe the department is making the kind of progress towards reform that this committee wants to see. I think that there's certainly room for additional conversation moving forward at some other point about pilot projects and carve-outs. I have heard all that and it's piqued my interest, but I don't believe that time is now. And with that said, I will not be voting in favor of this bill.
I had a couple of questions on my own. The gist of the bill is to do what we can to make sure that members getting main care services get them in an efficient and responsible, effective manner. Do we have national comparators for that we could use that would just give us, I know there's probably lots of them, but do we have any high-level comparators that would give us a sense about how efficiently run our main care program is, how our quality metrics compare to others?
We can certainly work on pulling some of that information together for you.
Because I think that's at certainly well, when we listen to the managed care presentations, efficiency and the potential for cost savings was one of the things. The ability to address social determinants of health was another, in that's traditionally outside the purview of main care, but has been getting gradually brought in. So I just wanted to highlight those two areas. If we could have some information about that, that will be helpful in our future considerations. Have there been organizations, to change the subject slightly, that have appreciated some shared savings in the ACO model that you've talked about with the experience that you had? Have there been organizations who in fact were able to split some savings? I see heads nodding. Yeah.
You want me to?
Absolutely. Olivia has.
Yeah. Yes. So I don't have it pulled up right now, but it was just under $10 million over 8 years that we've been able to share back with our accountable communities partners. But the savings achieved to the state and the federal government as our payer partner, it exceeds 30 million. So there are hard metrics associated with the shared savings program that we can provide in more detail about what that means. And again,
thank you. That's exactly what I was looking for. Some sense that we can quantitate some of the efforts being successful. My other question was 115,000 are currently in accountable care organizations. That represents what percentage of the total main care enrollee population?
Given that we've been quickly expanding, I would say it's about a third right now.
A third? Okay. And then the other thing that's notable about the bill and the whole discussion is the timeline for these things. So you mentioned glide paths. 40% is the goal for this year. What's it look like out 2, 3, 4 years in terms of percentage penetration of alternative payment systems? If that's as close as we're going to get to a more traditional managed care?
That's a great question. And we honestly haven't picked our next benchmark. I will say that the APM goal of 40% is looking at payments tied to value, period, but there's a big range of what alternative payment models look like, right? And Olivia shared that in summer 2023 is when our AC model will be going to a shared risk model. So right now, if the AC achieves savings compared to their benchmark total cost of care, they share in those savings. But if they end up costing more than anticipated, then the state is the one that has paid for those costs that were higher than anticipated, right? So starting in summer 2023, the ACs will share a percentage of that, so they will be at risk, and that is a big move in terms of accountability, and we acknowledge that. But that shared accountability is a big part of the reason why states move to managed care is because they experience reduced risk themselves. And so I think that we will absolutely continue to aim beyond 40%. The national progress and goals on that will inform our decision of our next benchmark. But also our APMs themselves are going to be increasing in accountability and impact. So that's important to note.
Okay. And then finally, your response to the idea of a study group. You mentioned that you were getting information internally, locally, and nationally. Would a funded effort in a study to look at pros and cons of managed care or what other states have learned and then report back, would that be helpful in our efforts to advance alternative payment systems and efficient care? That's no response time, and I understand that short notice, but if we funded a couple of positions and some staffing, would that allow you to better delve into what managed care or for main care might offer in this state and what hurdles, potholes, barriers, challenges we might face, so we'd even be better informed than you can do with the resources you have now?
I can jump in here. I think the decisions that Maine Care has made about the direction to go with improving the value of care have not been because of a lack of review of managed care as an option or any of the, potential risks and benefits of that. And so I think that those opportunities are incorporated in the thinking that Maine Care has, been applying to this work over the last few years. And so for Maine Care's benefit, I think that that's already part of the thinking. Obviously the legislature's prerogative if you would like to do a study of your own, but I don't think that the decisions that have been made have not been for a lack of understanding or exploration of those opportunities.
And I just want to be clear that I totally respect the efforts that have gone on with the resources that are there. And I understand that Olivia and Director Prover have brought lots of expertise and perspective nationally. I just wondered if additional resources might be helpful to further extend that. So I just want to raise that as a possibility. Thank you, though, Molly. And I really want to be clear that was not any sort of question of the effort or the resource allocation in the department. That's not part of my job and nothing I'm interested in. All right, I don't see any other questions. Thank you. That was a series of questions and comments. I appreciate that. So any other comments, questions? That being the case, then I would entertain a motion related to LD 1701. Yes, Representative Javner.
Thank you, Senator Claxton. Just before there's a motion, I just want to request that we have the capability of having a quick 5-10 minute caucus before we actually take the vote, please.
That would be perfectly all right. Why don't we reconvene at 11:20? That'll be 10 minutes. And it's time for a break anyway. And that'll give time for a corner caucus. All right, all those in favor of taking a break until 11:20? We'll do that. Very good. Thank you, Representative Jadner. Okay. We'll reconvene. Sorry, it's a little later than intended, but any additional questions before we entertain a motion? Any concerns? All right, I will entertain a motion. Representative Stover?
Holly, you're on mute.
We need to make that mute button bigger.
Thank you. Thank you very much. Mr. Chair, I'd like to propose an amendment. Should that come after the motion?
Sure. Can you tell us where you're going?
I would like to propose an amendment that the department provide for us a feasibility study that would include the possibility of a main care dental care managed contract, what that could look like, the pros and cons. So I think that may come after this, but I didn't want to lose sight of the fact that I think there's still part of this we could have a discussion about.
Thank you. Representative Meyer?
Just some clarity around Representative Stover's suggestion. Would that be an amendment or would that be a letter to the department?
I think that actually be a letter to the department. Thank you. To make that request.
So do you want to count that as well, we need a motion on the bill itself. So yes, Representative Zager.
Thank you, Mr. Chair. I like the idea that Representative Stover just suggested. I also have tremendous respect and regard for Representative Millett and the bill sponsor, the work that he's done on this, and would be in favor of such a letter. And unless there, well, it looks like there's further discussion, but I would motion that this bill, as written, ought not to pass.
Is there a second for that?
Second.
So the motion is ought not to pass with the understanding that there will be a request for a letter to follow. It's been moved and seconded. Is there additional discussion of that? I don't see any. Is your hand still up, Representative Stover? No. Okay.
I believe Representative Javner has a hand up.
There, Representative Javner.
Yes, I apologize. Thank you, Senator Claxton. I'm in absolute full agreement with the letter. I think that carving out, the dental services is going to be a really great piece for us. I just really want to reiterate how important this whole discussion has been, I think, for every single one of us. And also just for the department, I know they know this, but that we really want to keep you accountable for what you have said that you are doing. And that I think that that'll be really important. And so thank you all very much for everything that we've learned through this process has been invaluable.
Thank you, Representative Javner. So there's a motion on the in front of the committee, ought not to pass. It's been made and seconded. So we'll turn that over to Karen to run the vote.
Thank you, Senator. Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Javner.
Yes.
Representative Javner, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Connor. Representative Connor is absent. Representative Griffin.
Yes.
Representative Griffin, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. Thank you.
Representative Stover, I understood you to be looking for a letter to the department that would result in a feasibility study looking at the pros and cons of contracting for dental care.
Yes, a feasibility
a-
study, possibility of a main care dental managed care contract. in
And with a delivery of
January.
1/1/23.
Yes, thank you.
Any discussion of that? So I think we can do this with a show of hands, there not being any question. All those in favor of sending such a letter to the department, please so indicate. So that's unanimous of those present. Very good, thank you. This was offered with significant respect for the effort the department has put in to get us to where we are, with the understanding of some ongoing follow-up of performance in terms of efficiency, access, and quality, and with the great appreciation for all the work that Representative Millett has put into this over a effort and thought over a long period of time. So thank you, sir.
Thank you, Senator, and thanks to the committee for your work.
All right. Need anything from us, Anna? You're good with? Okay. So moving right along, let's move to consideration of LD 1608. Again, in this instance, we will not have a report from an analyst because we considered this bill in the prior session. There is no additional documentation that I'm aware of since the last hearing. So I'd entertain any thoughts or questions that people have about LD 1608. And looking for Representative Sylvester, or whether, yes, he is in the, we'll promote him to a panelist.
Yep, he's on his way.
Yeah. Welcome, Representative Sylvester.
Thank you very much. I'm turning on all my doodads.
There you go. Your
Thank
doodads
you,
seem to be
Chair
working.
Claxton, Chair Myers. Appreciate you having me in.
Sure. Looks like there's a couple of questions, and then we'll give you a chance to give some feedback. Representative Craven. Representative Craven, did you have a question?
No, thank you.
Okay. Representative Zager?
Thank you, Mr. Chair. I was rereading the bill, and I couldn't see in there a provision that would guarantee people, if they're happy with their current insurance, health insurance, that they could keep that. So if Anna or anybody else is aware of that it's there, please correct me. But if not, I would propose that as an amendment to the bill.
Okay, so we could go to Representative Sylvester and figure out whether he would regard that as a friendly amendment or not.
I would indeed consider that a friendly amendment. I think that the point of this is to make sure that people are covered in a way that they like, and so that would to me be a responsible amendment to put in there.
Okay, any additional thoughts about that? I'm not seeing any. So as it stands now, we have a bill and an amendment. Next, we need a motion, and I'll entertain. Yes, Representative Craven.
Thank you, Mr. Chair, and thank you, Representative Sylvester, for bringing this forward. It is definitely a concept that I agree with tremendously, for everybody to have coverage. However, I'm actually not going to be supporting the bill for the following reasons. And that is that we just had a 2-hour conversation with the department with the overwhelming amount of work that they're putting forward, and just trying to get our feet under ourselves for the new expansion that we just did. And also I think the evidence that came from Vermont and also California, in that they gave it a great effort, and because of their population, especially the lack of population in Vermont, as much as I liked their policy, failed. And also, you know, at the end of the day, nothing is free, and so how apt are Mainers going to be to pay publicly for such an expansion? And so, with I just wanted to say those things, and with regret, I won't be supporting the bill.
I don't see any other comments or questions. Did you want to make that as a form of a motion?
Yes, from my own opinion, I would just move ought not to pass. Thank you.
Is there a second for that?
Second.
So I see Representative Javner seconded that. Is there additional discussion? Representative Madigan.
Thank you, Mr. Chair. I agree that we have gotten a lot of information from the department on things they're doing. I like Representative Zagar's suggestion about an amendment so that people could keep their insurance. I'll be voting against the motion because I just support everyone having access to health care. Thank you.
And since Representative Sylvester regarded the amendment as a friendly amendment, it really is, as I understand the motion from Representative Craven, it's ought not to pass as amended. Okay. I see Anna with a quizzical look on her head.
Ought not to pass as amended is not a thing.
Well, I know.
Okay, just checking.
But let's just make sure we're all on the same page. I'm trying to make sure we're all on the same page.
Can I continue to look confused for a minute?
Sure.
I'm confused about what Representative Zager is. I mean, I understand what Representative Zager is saying, but I'm confused about how it fits with the bill. So the bill's idea is main care for everyone, and you're talking about people who are currently happy with what they have, sticking with what they have. So I'm not, it might be that I'm just too much on the hop here, but I'm having trouble figuring out how to put those two things together. But I'm continuing to think about it.
Okay. Representative Sylvester, your thoughts?
Thank you, Senator. So to me, the bill is tiered and has portions and years in which people can opt in by paying into the system. And one of the things that will be configured by the commission is how exactly that works. There's a series of things that the commission has to figure out: how to get a waiver from the federal government, how to pay for this, and then there's another authorization bill for payment that comes forward. And so really what this bill is about trying to figure out how we get that done. And the reason this seems like a responsible amendment to me is that one of the things that people might opt to do is to keep their current plan, and the committee would figure out in what fashion that would work and meld with the plan. Because if they have coverage, then we are providing coverage to all Maine citizens. And I think, may I extemporate for 30 seconds?
Sure.
Mr. Chair? I think that, that's really what this bill is about. It's about trying to figure out, this is an idea that has been around for a long time, providing universal care. One option is to provide it through Maine Care. And this is a bill about figuring out whether this is a feasible thing to do. It would be a series of people who would be willing to have the time to look at that, as we do in the legislature all the time. And I know that you are a committee that likes to know whether things can work. We are in a health position right now where we are seeing not only our hospitals exhausted, but also our private insurance is facing an exhaustion of the things that they're being asked to cover and provide. And I think that to wait until we're in a crisis mode where those systems are failing to see whether or not there's another system that could work, that would need to come back in front of this body in its final form to see whether or not we wanted it to work, to me just seems like responsible government, that we would go ahead and try to figure out, can we provide Maine care for all Maine citizens? So that's my editorial. You know the bill. We've done this a couple of times. I appreciate all of your hard work on this committee, and I thank you for the time and your consideration.
Thank you for those thoughts. Any other comments? Or yes, Representative Madigan, is your hand up again or still? Or okay, Representative Perry?
Thank you. And I would love to see some sort of insurance plan for all. We just had a very significant report about what Maine Care is doing to cover the people they have. We have a number of programs that are provided by Maine Care that have waiting lists because they don't have the resources right now to fully fund those programs. And these people have Maine Care. We've just gone through a crisis, and I agree the pandemic has been a crisis. It has hurt insurance companies, it has hurt Medicaid, and it has hurt Maine Care because of the amount of expenses because of hospitalizations and long-term hospitalizations as a result of this pandemic. I would love to see something, but I don't think this is the time to do this. I want to see the work that's being done by Maine Care to make sure that we are covering everybody who is waiting for services before we start expanding. Thank you.
Representative Lemelin.
Thank you, Senator. I just wanted to make a quick comment, and that is I'm an ought not to pass. The department just testified that they are working diligently towards fixing a lot of issues and certain reforms, including proper fee structures. It indicated to me that not that they can't handle that, but they're in quite deep. And adding this to the plate, I think we as a committee would be drowning them. So that's my only comment. Thank you, Senator.
Thank you, Representative Lemelin. Any other comments? So, Anna, are you less quizzical at this point?
Certainly.
Okay. So the motion has been made and seconded on an ought not to pass. So we'll ask Karen to run the vote, if you would.
Certainly, Senator. Representative Zager.
No.
I'm sorry, I missed that, sir.
No.
Thank you. Representative Zager? No. Representative Lemelin?
We're voting on ought not to pass, correct?
That's correct.
A yes.
Representative Lemelin? Yes. Representative Stover?
Yes.
Representative Stover? Yes. Senator Baldacci?
No.
Senator Baldacci? No. Representative Perry?
Yes.
Representative Perry? Yes. Representative Javner?
Yes.
Representative Javner? Yes. Representative Madigan?
No.
Representative Madigan? No. Representative Craven?
Yes.
Representative Craven? Yes. Representative Connor? Representative Connor is absent. Representative Griffin?
Yes.
Representative Griffin? Yes. Senator Moore? Senator Moore is absent. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
No.
Senator Claxton, no. Thank you.
So that's 7 yes, ought not to pass, and 4 no, with 2 absent.
Yes, sir.
And Senator Moore's on the phone. Would you like to cast a vote now, Senator Moore? Can you do so safely from the vehicle?
I can. I didn't know if I could do that verbally or if I had to be in video.
Yeah,
She has to be in video.
We do need to see you. So,
And I'm on the phone.
That's fine. That's fine.
All right.
Thank
and
you.
I will be registering my vote as yes, ought not to pass. But I'll give Karen a call later.
Yes, I will follow up with you, Senator.
Very good.
Okay, thank you. Thank you, Karen.
You're welcome.
Be safe.
All right.
So, yes, Representative Meyer.
Thank you, Mr. Chair. I should have brought this up before, and I'll bring it up now. Nonetheless, and that is LD 1045, which was Representative Brooks's act to support universal health care, established the Maine Healthcare Board that would be in place should there be movement at the federal level in this direction. And I just wanted to make sure that this committee was aware of that. It should be in your email from Anna last night, and also to thank Representative Sylvester for bringing this to us so that we could have this discussion. And to add that I don't think there is a single person on this committee that doesn't believe in the right to each and every Mainer to quality, affordable health care. And that even with a healthcare ID card in one's pocket, we have incredible disparities, racial disparities. We have a capacity problem. We have systemic problems that even with that card in your pocket, there are long waits for care. And there are social determinants of health where this committee has been focused, and as a legislature, we need to continue to be focused on improving social determinants like housing, education, childcare. It's endless. So we have a lot of work to do. And I truly, from the bottom of my heart, thank you for bringing this forward.
I thank the committee for your time. Appreciate all your work.
Thank you, sir. Okay.
So the minority is ought to pass as amended. Is that correct?
Yes, for me.
Okay.
Representative Zager, you okay with that?
Affirmative, yes.
And there were 2 other votes, no, or Senator Baldacci indicates he's comfortable with that. And so did Representative Madigan. Thank you. Okay. So that'll bring us to consideration of LD 1864.
Okay.
This time we do get an analyst report.
Yes, you do. I'm going to share my screen if I can manage to do that correctly. That is the wrong one. Hang on a minute. We'll try that again. Okay. Yeah. That's the wrong bill, but that's okay. Are you looking at 1864 now?
Yes.
Great. Okay. So, all right. I don't know if.
Can you click plus one more time?
Yeah, absolutely, I can. 100. Is that better?
It is now. Thank you.
Good. Okay. I don't know if you had a preference for which order you were going to do them in, so I'll just do this one first.
Sure.
So these are the next two are major substantive rules. And this one is the major substantive rule for Chapter 33, which is the family childcare provider licensing rule. So these are the smaller childcare providers. And the resolve allows for the department to go forward and adopt their rule. And this is an emergency. That means that it will, if you go forward with the resolve, once it gets signed, then the department goes ahead and adopts it, I think within something like 30 days, I think. So this is the one that the department requested a number of amendments to their rule. So if you do that, the way you do that is you allow the department, you authorize the department to adopt the rule with certain changes. That's the way that you would write that, or that we would write that. So they were requesting some amendments related to limiting the financial penalties and removing the broad administrative fines on the recommendation of the Attorney General's office. You heard from Dr. Landry that they only use administrative fines occasionally, and this would remove that critical violation language in the rule and the administrative fines that go along with that. The other changes are more technical. They're related to immunization and running water, but and they're in response to the comments that they received on the rule at the public hearing, and whatever comments they received, written comments as well. So the immunization and running water language changes that they're asking for are purely technical in nature, but I can certainly bring them up if you would like to see them. The running water one, for example, is originally the bill, I mean, the rule was requiring hot and cold water, and I guess there were a number of comments that said, you know, water is water, and so that hot and cold was struck out. The immunization language is just shunting around the way the language was written. There are changes to some of these things from the original rule, but in terms of the one that was in effect until now, but in terms of what you were seeing, those are the changes that they are looking for. You did hear from the department and also the Family Childcare Providers organization, and I always forget what the AEYC stands for, but these are rule changes to comply with Childcare and Development Block Grant. The drafting issues are just the amendments that you heard requested in the testimony. And then just a reminder that the family childcare provider rules are combined routine, technical, and major substantive. So when you look at the rule, which hopefully you have, that there are, the way it's marked up with certain things shaded, and the shaded parts are the major substantive and the routine technical parts are not. So I just wanted to remind you of that. And that's because the law in Title 22 that around the licensing of family childcare providers determines that certain parts of the rules are major substantive and certain parts are routine technical. So the major substantive rule language, and you can go back to the law and look if you like, it's on the electronic record, and I can also click through to it, apply to child to staff ratios, health and safety of children and staff, waivers, suspension and revocations of licenses, background checks and license fees. And some of those things were not changed in this rule. For example, the child to staff ratios, that's a routine technical, a major substantive rule, but this rule doesn't make any changes to it. So it's still in the rule, it's still shaded, but I'm just letting you know that some of these things didn't change from the rule they had before. And then OFPR, the preliminary fiscal impact statement, that there's no fiscal impact. And just a reminder that in the rules that we had in place until now, the childcare providers, whether they were family childcare providers or the bigger ones, had language around background checks, and that's now in the other rule, which we'll get to in a moment. And this rule and the childcare, the bigger childcare providers are now just going to be cross-referenced. So there are a lot of other you're focusing on the other routine, the other major substantive parts of the rule here, because the background checks have now been put in
in another one, which I have to say is quite clever, because it does clever as in, I don't mean a good strategy. I mean, it makes it easier in that you now have one rule that has major substantive pieces that applies to all kinds of childcare providers, and it's less rulemaking for everybody. And I do know you have Dr. Landry in the wake room too.
So technically, I guess this is your bill, Representative Meyer. Are you accepting the department amendments as friendly amendments?
Certainly.
Okay. So any questions, discussions about this? So I'd entertain a motion on this amended bill.
I'll move ought to pass as amended.
Thank you,
Second.
Representative Perry, and seconded by Representative Craven. Thank you. So there's a motion on the floor, ought to pass as amended. And any questions, discussion further? Not seeing any, we'll ask Karen to run the vote. On LD 1864, the motion is ought to pass as amended.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Javner.
Yes.
Representative Javner, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Connor. Representative Connor is absent. Representative Griffin.
Yes.
Representative Griffin is yes. Senator Moore. Senator Moore is absent. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes.
Very good. So let's move to consideration of 1865.
Okay. Are you looking at 1865? Hopefully.
We are.
Great. And I even blew it up big for you.
And well
Okay.
magnified.
So this one is even more straightforward than the last one. So this is the background check licensing rule that I mentioned, the major substantive rule. This is a new rule for background checks. It was previously, as I mentioned, separately included in two different rules. Now it's been pulled out, put into one rule, and is cross-referenced into those other rules. And this is the rule that adds requirements for pre-employment and pre-licensure, I can't say that word, comprehensive background checks as required by the federal government. The department has been doing background checks. These are fingerprint-based background checks since July 2020. They are paid for by block grant funds, so that the childcare provider and the potential employee doesn't have to pay for it. And the average turnaround is 4.5 days, and non-compliance would result in federal penalties. So this is a federal requirement. This was a major substantive rule that was adopted by emergency in September 2021. This proposed rule makes no substantive changes to that rule. And this rule has an effective date of September 25, 2021, so that the background check rule doesn't lapse. And I know that there were no comments received during the rulemaking period, and there's no fiscal note for this either.
No amendments that we're aware of.
No.
So any questions, discussion about LD 1865? Yes, Representative Craven.
Thank you, Mr. Chair. I didn't have any discussion, but I was going to make a motion. Ought to pass.
Thank you for that. And seconded by Representative Zager. Very good. So the motion's been made and seconded on 1865.
Actually, 1864. Isn't it? Did I get mine wrong way around?
I have.
No, you're right. You're right.
That's twice this year. Okay, so We have a motion in front of us on 1865 ought to pass. It's been made and seconded. I turn it over to Karen to run the vote.
All right, Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Javner.
Yes.
Representative Javner, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Connor. Representative Connor is absent. Representative Griffin.
Yes.
Representative Griffin, yes. Senator Moore. Senator Moore is absent. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. Thank you.
Very good. Next, we'll move to consideration of 1761, LD 1761.
Okay. All right, hopefully you are looking at 1761.
We are.
Okay, so this is an act to amend the inspection requirement for facilities for children and adults with a national accreditation. This is a department bill. Current law in section 7801 subsection 6 provides that if a person, firm, corporation or association operating a residential care facility, assisted housing program, drug treatment center, children's home, child placing agency, childcare facility or adult day care program has received and maintained accreditation from a national accreditation body approved by the department, the entity must be deemed in compliance with state licensing rules. This bill instead provides that the entity may be determined by the department to be in compliance with state licensing rules rather than being deemed to be in compliance. And you heard from the department that this is related to the QRTPs and the Family First Act, that all children's residential facilities, in order to meet those QRTP standards, have to be nationally accredited, which would mean that they would be deemed in compliance under current law. And so you heard from the department that accreditation inspections are not frequent, and that the change in this law would allow the department to inspect as they need to ensure that they are meeting the QRTP standards, for example, in between licensing or in between accreditation. You did hear from the Alliance that they're neither for nor against, that the law already allows for inspection in response to a complaint, and that there is a concern about administrative burden on providers, and that national accreditation should be accepted as meeting the quality standards if there aren't complaints. So I did have a couple of questions about this, about whether other facility types other than children's residential facilities that are licensed under this section are nationally accredited. This language would apply to all of those types of licensed bodies. What I don't know is whether there are accrediting organizations approved by the department that would be affected. Although, the purpose of this, well, first of all, you heard about this because of the QRTP conversation. So this is an OCFS bill. This is their focus. But it means that if there were another type of licensed body, I don't know, a children's home where there's an accreditation body that is approved by the department, that it would also mean that they could be inspected, which might be fine, but that's up to you. I did ask whether the section 7804 that allows the right of entry to determine a state of compliance for the facility license under the subtitle, whether that would allow the department under current law to go in and inspect. And I don't want to speak for Dr. Landry because he is here, but I did get an email that said that there are some situations in which those two sections are in conflict. And you could argue that the language of license under the subtitle is not exactly the same as accredited. In other words, the right of entry applies to facilities that are licensed under the subtitle, and that may not be exactly the same as an organization that is accredited. And so this would allow, make it completely clear in the law that the department could go and inspect if they need to ensure that compliance. And I think that's all I had. We haven't yet received that from OFPR, but I don't imagine that there would be a cost.
Very good. So, Dr. Landry or Molly, can you help us understand a little bit of the nuance between licensed and accredited and the impact of that and whether other facilities are impacted?
I can certainly, attempt to do that. I think Ms. Broom did a nice job of explaining the two different sections there of 7801 and 7804. And the real purpose of this bill really is to ensure that there aren't any conflicts between the two, because there could be, I'm not saying there have been, but there could be situations, and I'll use Ms. Broom's example for a moment. In one of the organizations I led in the past, for example, we were COA accredited, and that applied to the entire organization, regardless of the type of service we were providing. And you certainly could have multiple services or multiple facilities within one accreditation that may not necessarily be applicable. So let me give you a more specific example. We were accredited for our child care program. We were accredited through the National Association of Education of Young Children. And so we had that accreditation. So technically our agency was accredited. However, that had nothing to do with our residential facilities. And so there sometimes could be that potential conflict that we just want to make sure does not arise in the future. Again, I don't think it has necessarily, but as we were looking at these statutory references, we wanted to make sure that those were cleared up. There could also be a second part of the reason that we feel this is important to ensure there's no conflict between 7801 and 7804. There could be a small number of situations where the department is actively involved in reviewing or has recently completed, for example, investigation and is working with a provider, in this case, a residential provider. And let's say that it's time for their regular licensure renewal. Well, we would certainly want to continue those conversations and use the renewal opportunity as a way to ensure that there have not been a reoccurrence of any of those concerns or other concerns that may have come up. The way the statute is currently written, if they're accredited, they're automatically deemed to be in compliance with with the licensing standards, I should say. And so that would prohibit us from being able to do that. So again, this is really about just being very clear in our statute to ensure there is not a conflict. And that is to, as we saw it, the easiest way was to clean up in the current section and changing the word from must to may from that perspective. The second question, I think, was about other facilities. We have certainly addressed this with our sister organization and office with DLC, and we do not, and we're told that while this does impact other types of facilities, there is no anticipated impact on those situations.
Okay. Molly, did you have anything to add? Okay. And we've been joined by Mallory Shaughnessy, who had her hand up in the attendee list. Welcome.
Hi, thank you for acknowledging me. I just wanted to speak a little bit more to the difference between the national accreditation and the state licensing rules. And many of the providers out in the community doing behavioral health and other services are seeking national accreditation because we're looking for sort of uniformity across the country of standards. And often they are higher standards than some states have on record. It's a huge lift to get the national accreditation. And part of that under the current statute is that, for an agency to take that big lift and get accredited nationally, would hopefully then lift some of the burden of them getting these constant kind of periodic state licensing reviews unless there were concern that arose. So it's to lessen the administrative burden, but to meet a higher standard. So just sort of wanting to talk a little bit about that. And, you know, as I say, many of them have been seeking national accreditation, and with the QRTP, they have to seek the national accreditation. Under current statute, the department has the capacity to go in and review compliance with any state licensing or standards in response to any kind of a complaint. And Disability Rights Maine often comes in too in response to things that are brought to their awareness. So even though they may have national accreditation and maybe a 3-year cycle, it's a higher standard, and there are other mechanisms for oversight at the local level. So just wanting to kind of talk a little bit about those two pieces and some of the concerns about the administrative burden. So especially with COVID and, you know, crisis of workforce, but just sharing that.
So are you saying that this bill would potentially increase the administrative burden?
Yes.
Is that yes, potentially.
Yeah.
Yeah, because it expands the reasons for, well, the opportunity for visitation or checking.
Yeah, there's no, yeah, it just would, right now they are totally capable of going in and reviewing compliance if there's any kind of a complaint. If somebody has reached that national accreditation. But this would just kind of open it up.
Okay. Any response to that, Dr. Landry, or address those concerns?
Certainly, we applaud and support and have financially supported the work of the agencies, or many of the agencies, to become nationally accredited. We think national accreditation is one piece of many pieces related to improving quality, and it is part of the QRTP, of course, standard. However, having led organizations before that have been nationally accredited by COA and others, I think it is just important for the committee to recognize that national accreditation review typically happens on a multi-year basis. And so while there are reports that go in, the aspect of any type of on-site visit from a national accrediting body is generally, 3 years, although it can be either 2 or 4 years in some circumstances as well. And so a lot can happen during that time period. And so that's why we believe we should have the ability for the safety and health of the residents, the youth in those facilities, to be able to provide the oversight in 7801 when it is needed. Again, we're suggesting that the language simply be changed to may from must, and so it does not mean that it would necessarily increase any type of visitation, but it would give us the opportunity to do that and continue to work with the providers to ensure the safety and health of the youth in those facilities.
Thank you for that. Any other questions of the folks who joined us, or about the analysis from Anna? I'm not seeing any. So at this point, I would entertain a motion on LD 1761. Representative Craven?
Thank you, Mr. Chair. I move to pass. Is it amended?
Somebody second it?
Second.
I'll second that.
Okay. Representative Perry's voice got there before your hand. Representative Stover. So it's been made and seconded. Ought to pass. Any further discussion? And we'll turn it over to Karen for the vote.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Jabner.
Yes.
Representative Jabner, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Connor. Representative Connor is absent. Representative Griffin.
Yes.
Representative Griffin, yes. Senator Moore. Senator Moore is absent. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. Thank you.
Thank you, Dr. Landry, and thank you for sharing those concerns, Mallory. Next, we'll go to a consideration of LD 1849.
Right. Hopefully you are looking at 1849. Okay.
We are at 100%.
All right, so this is another one of those accreditation bills. So this is an act to clarify inspection requirements for hospitals and certain nursing facilities. This bill removes the requirement for nursing facilities providing both nursing home and assisted living services to receive a single coordinated licensing and fire code inspection. The nursing home services inspections occur at varied intervals between 9 and 15 months apart based on a facility's performance with CMS conditions of participation, while assisted living services inspections occur on a 2-year cycle and are required prior to issuance of full licensure, making the requirement in current law not feasible. And then the bill also provides that a hospital that is exempt from inspection from the department, if it submits to the department a copy of its accreditation survey report results completed by a healthcare facility accrediting organization, including a statement of any deficiencies and corresponding plan of correction. So that's what the bill does. You heard from the department, well, actually, you heard from amendment requests. So the department so there was a mistake in the way the bill was printed. Instead of saying the Department of Licensing and the Division of Licensing and Certification, it had said main care. The current law actually has DLC, so that was just an error, is my understanding. So that's a correction. And the other correction was including full license language. The way the bill is printed right now, it just says license. And so that would be including full into lines 10 and 16. That would say a full license may not prior to issuance for full license. That's actually just a return to current law. And then you also heard a request from the department and from the Maine Hospital Association to amend that section relating to accreditation, that's providing the accreditation survey results to the department. There's an amendment to include language that would maintain the confidentiality of those accreditation surveys outside of the department. You heard that those surveys are already confidential, and this would keep them confidential. In other words, they wouldn't be FOIable. They would be provided to the department, and then the department would then be required to keep those accreditation surveys confidential. And so you heard that the Hospital Association is not opposed to the bill with that amendment language. And then you also heard from the Healthcare Association, which is the nursing facility folks, and this is related to the inspection part, request for language that prevents undue duplication of effort in surveying multi-level facilities. So I just want to, so you received an amendment attached to Bill Monteo's testimony, which I can certainly bring up if you need. So that includes the confidential language request that you heard about. And it also includes language that is confidential, not a public record, not open to public inspection. That's a whole lot of things that all mean the same thing. And there was a lot of work done by the Right to Know Advisory Committee over the interim around standardizing confidentiality language in the statutes when we're drafting it. And I sent that along in case you wanted to see all the sort of reasoning for that. But it's confusing to have all those different pieces of language that mean exactly the same thing. And so if you want to move forward with the amendment that's requested by the department and the Maine Hospital Association, the recommendation is that you just say these records are confidential. They are released to the department, but they are confidential. We don't put any of that other language in. It's a little bit inside baseball and what I did on my summer vacation, because I did spend a lot of time in the summer thinking about this stuff. but that's just a technical issue. And just a reminder too that including that language also triggers a freedom of a public records exception review by the Judiciary Committee. But that's just also a technical issue. And I'm happy to bring up the language, although I will have to find it first, if you would like to see that again.
Yes, Molly.
And just perhaps to save Anna bringing up the language, I think whatever language achieves the goal is fine with us.
Both with respect to the language changes of the bill and the language around confidentiality.
Yes, yeah.
So we have a bill that's been amended with what's largely technical. Representative Perry.
I'd like to make a motion to ought to pass as amended with the amendments recommended by Anna.
Second.
Second by Representative Craven. Any further questions, discussion? Then we can turn it over to Karen for another vote. You notice I've been trying to be good about flagging who made the motion and who seconded it.
Thank you. I appreciate that,
That was a
Senator.
request from the team.
Very much. All right, Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Javner.
Yes.
Representative Javner, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Connor. Representative Connor is absent. Representative Griffin.
Yes.
Representative Griffin, yes. Senator Moore. Senator Moore is absent. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. Thank you.
Thank you. Okay, let's move to consideration of LD 632. And this is one of those bills that was held over. It would have provided money to help with the PNMIs meet QRTP standards. And the question is whether that's necessary or not. And I have a couple questions, and we'll bring in Ken Olson for his perspective. But as long as we have Molly and Dr. Landry, can you give us a sense from the department's perspective about how things are going with the transition to QRTP standards?
I'd be happy to jump in on that. Senator Claxton, as I've indicated before, my thanks and appreciation to our children's residential providers in the state for working with us in order to meet the new federal standard requirements for qualified residential treatment providers, lovingly known as the QRTPs. That new standard, we think, helps move our state in the right direction as far as quality for children's residential programs. I'm happy to say that 9 of the 10 residential providers in the state have met most or all of the QRTP standards, particularly the accreditation standards and some of the trauma informed care practice standards and those pieces. I know some of our providers are at earlier stages of meeting the full level, if you will, of those standards, and we're certainly working with them to do that. I'm happy to say that we had the availability of federal funds through the Federal Family First Transition Act dollars that we were able to utilize to provide direct reimbursement and support to our providers to either reapply for accreditation, for example, or to apply for the first time for accreditation, as well as some other expenses related to that. I also want to say my thanks to our Children's Behavioral Health team, as well as Christine Therio, who has been leading our work on Family First implementation in working with all the providers over the past year and a half to get us to this point. So we're well on our way. Again, my thanks and appreciation to the providers who have committed to this, and my thanks to our own staff who have been working with them diligently over the past year and a half to provide support, including financial support.
Thank you for that. Molly, anything to add? Okay, so we have the department's perspective. I'll invite Ken Olson to share the in the trenches perspective.
Yeah, thank you very much for the opportunity. I think that the department needs to be commended for its efforts around rolling out the plan. I think, if you read the details of this legislation, it asks OCFS to develop a plan for implementation. I think they did a really excellent job of that, including the involvement of providers with a clear intent to improve the quality of services that are provided by the residential programs for kids in Maine. So that element of it is only the only caveat that I have to that is that in all of those conversations, while the goal here was clearly to improve the quality of services to kids, it had to be with the caveat from the providers that adequate funding be provided in order to be able to meet these new standards. And the reality of, so I think that the standards and the efforts on the part of providers and the efforts on the part of the department of OCFS in particular to get us to this point are in rather complete alignment. The only misalignment comes around the funding question, where, and this is partly because of the pandemic, it's partly because of inflation, that the providers tend to take issue with the rates. Although we've seen a significant increase in rates for the services, they have not been rate increases that have allowed us to increase our capacity in these programs. So we're still struggling with unmet need of kids referred to these programs and facing the workforce challenges that I know you've heard a lot about, facing now inflationary challenges. The rate increases that we received were based on a rate study that included information that came, basically 2.5 years ago now. And, I can tell you that, at Kids Peace, at my organization, we've seen substantial increases in costs of workforce in terms of direct care staff, substantial increases in our challenges around hiring nurses, for example, another clear example. So with perhaps the single exception, I think there's still some muddy waters with respect to the aftercare services that are being provided by providers and are required under the Act. And we're still kind of going back and forth with the department over figuring out exactly what that program needs to look like and how it needs to operate. It feels to me very much like we have moved forward in the right direction, but I can't lose the opportunity here to remind you all that if the intent was to increase access to services of becoming a QRTP, we have not achieved that, and that's mostly a function of rates and what we can afford to do in this business climate.
Thank you for that input. Molly, did you have something else to contribute? Mallory, did you have something? I'm sorry, Mallory. It's my lunchtime.
Yeah. Sorry. Was Molly, were you going to step in? Looked like you popped up to say something.
No, I thought I was being asked, so I'll floor is yours.
My bad.
Thank you for calling on me, Senator Claxton. Yeah, I would reiterate the concerns that Ken just presented. Many of the QRTP providers, residential providers, are members of the Alliance, and we have had some very hearty discussions around this transition to QRTP and the need for rate increases. And as you know, we've been in front of this committee and in front of the legislature for a number of years, seeking rate increases for children's PNMI. The rate increases kind of brought us to level, but they didn't bring us advanced into QRTP land as well as is needed. And I think there's some real concerns around aftercare and how that plays out in the new rate and the capacity to sustain that, which is a critical component of the QRTP. Some of our providers have done some calculations on what that looks like, and it really is not a self-sustaining model. So there are definitely some concerns continuing on some of the specifics that I think, having some kind of continued oversight and maybe a stakeholder group that continues to work on this and reports back on a regular basis to this committee or in some future date might be good so that we can continue this transition. It's a huge transition, and it's not kind of a one and done type thing. So if there could be something that continues this oversight, that would be great. And I think very helpful for the system as a whole.
Dr. Landry, did you have some thoughts in response to those comments?
Certainly, and thank you for the opportunity, and my thanks to Ken and Mallory. As they have indicated, we've worked, I think, very diligently, and I appreciate Ken's comments about the commendation to the department on working with the providers during this process. I feel very pleased about the work that was done there. The rate study that both Ken and Mallory referred to was done in 2020, and this committee, of course, and the entire legislature included the rate increase in the budget that was passed last session. It was an increase depending upon the category of the PNMIs, as they're referred to here under main care, anywhere from 45 to 75%. They did include the QRTP requirements. The aftercare components was agreed to be pulled out and be able to be billed separately. I recognize that there is still some work happening around the aftercare piece, and that's part of our commitment, was part of our commitment and continues to be part of our commitment to the providers, continue to work with them, because the aftercare component, which I think we all would agree is absolutely essential, is fairly new and is quite new for most of the providers in the state of Maine to provide that aftercare to youth once they leave the structure of their facilities. And our commitment is to continue to do that. And Senator, we would certainly commit from the department's perspective to continue to provide ongoing updates to this committee as it relates to the implementation of QRTPs as part of the overall implementation of Family First as we go forward.
Can you speak to whether there is additional funding or when the next rate review might happen?
Well, the rate review would fall under, of course, the main care area, and without speaking directly for them, I believe the commitment as part of the department has been that we're committing to do ongoing regular rate reviews, and so I believe in general the time frame that has been talked about that is on a 5-year basis with the COLA adjustments happening in the interim components. In the meantime, we continue to work with the providers on pandemic relief opportunities, some of which do apply to PNMIDs as they're referred to in the main care rate. And we certainly will continue to work with providers to ensure those opportunities are made available whenever possible.
Mallory?
Thanks. I would just highlight that point that Director Landry just made, and want to echo as well Ken's comments. The department has been put in a lot of time and effort. They've really reached out. There's been a lot of collaborative work throughout this process, and we hope and think that it will continue. The concern is, we did just get this rate review last year. We're in the middle of a structural reform of how children's residential is done, and different indicators that are being added to it. To wait another 5 years for another rate review seems to be too far down the road when we don't know for sure if it's really going to meet the need. And we don't want to go through what we've been through, where we see this attrition where, we've got half the beds that are out here are unstaffed because they couldn't afford staff to staff the beds because of the rate and the stagnant rate that we've had. So just if there was some way to have a work group of stakeholders in the department, and then report back next year, how is this working? Does it need to have something before that next 5-year indicator comes up? So just to reiterate that concern.
Yeah, I heard a departmental commitment to that. Would that meet your or address some of your concerns, Ken?
Yeah, it would. It seems to me like the metric that your committee and the public policy folks need to have in mind are the outcomes. And the outcomes have to do with what constitutes acceptable access to services and what do we need to do from a public policy standpoint to ensure that there is adequate access to services. Mm-hmm. And to Mallory's point, right now, we sit with all sorts of empty beds in the state and many, many referrals to these programs that we can't meet, and access continues to be a significant problem for us. And to that end, I think, coming together at least on an annual basis to really analyze that question of, are we meeting the standard that we want to meet to ensure access to these services, and what do we need to do to address the problem if we're not meeting that standard?
Okay. Was there a designated work group that was part of this, or was this more informal? And because that's a group we could tap for a report next year.
There was a designated work group as part of our Family First implementation that focused very specifically on residential services. With the implementation and approval of our Family First plan, that has largely then been moved over to oversight and ongoing work in children's behavioral health services, as well as some continued support from Ms. Therio as it relates to Family First and the connection there. So that work group, I do want to be clear, that work group we made a commitment to our providers that we would convene that for the implementation and planning for Family First, so that they didn't have an ongoing commitment that we were asking them to make from a staffing perspective, because we heard from them about some of those challenges that they have about the burden of that. And so we made that commitment. I'm confident that if the interest is of this committee, I'm more than happy to say that we would commit to reconvening that work group in the intervening period between the end of this session and 23, and provide a letter response to the committee on what occurred and what were the key findings.
That sounds good to me. With the inclusion of the work group and input from the people who are doing it. So I see some head nods. Is that if that's acceptable? Any other questions for anybody related to LD 632? So at this point, with that in mind, I'd entertain a motion ought not to pass for 632 with a subsequent letter to go to the department asking for a report in 2023 involving input from the work group. Representative Meyer?
So moved.
Representative Perry?
Second.
So it's been moved and seconded. Is there additional discussion? Not seeing any. Thank you everybody for their input, and we'll turn back to Karen.
All right. Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Javner.
Yes.
Representative Javner, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Connor. Representative Connor is absent. Representative Griffin.
Yes.
Representative Griffin, yes. Senator Moore. Senator Moore is absent. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. Thank you.
And for the record, I appreciate your help killing my bill, but it was no longer necessary because of all the great work that's gone in so far. So I'm good with that. So it being 12:40, I think we're going to ask the indulgence of the presenter who wanted to go first at 1 o'clock and reconvene in a half an hour at 1:10, if everybody's okay with that. And then we'll start with hearing LD 1868 from Representative Clucci. Okay. Thanks, everybody. Good morning. Good mornings at work. Appreciate it. So we'll be back reconvening at 1:10. Thank you for being here, Molly and Dr. Landry, Mallory, and Ken.
Love your sense of humor, Senator.
I've been tried to get Representative Cloutier in the, she's coming, okay. So welcome back, everyone, for this afternoon session of the Joint Standing Committee on Health and Human Services. We'll be having a public hearing on two bills this afternoon, beginning with LD 1868. And in the interest of moving things along, I don't think we need to reintroduce ourselves. So, and given the fact that Representative Cloutier has a competing obligation, we'll let you dive right in.
Thank you so much, Senator Claxton. And hello, friends on HHS. Senator Claxton, Representative Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services. I am Representative Kristen Cloutier of Lewiston, and I am here to present LD 1868, an act to restore funding to the state's tobacco prevention and control program. In state fiscal year 22-23, this important program was cut by $5 million per year. And as a result, the program will see reductions in critical areas, including evaluation and surveillance, mass reach health communications and counter marketing, tobacco cessation programming, and targeted prevention and treatment efforts aimed at reducing tobacco use among those that disproportionately use tobacco, including the LGBTQ+ population, rural and racial ethnic populations, individuals with low income, and individuals with mental and behavioral health conditions, the same populations disproportionately affected by COVID-19. In addition, these cuts create more space for the tobacco industry to hook Maine's kids on their harmful products. While we are in the midst of a global pandemic, fighting a virus that attacks our lungs, we need to be doing all that we can to prevent tobacco use and to help current smokers to quit. Tobacco use contributes to higher risks for serious illness from COVID-19 and is the leading preventable risk factor for numerous other diseases that are the leading causes of death among Maine people, including cancer, heart disease, lung disease, and stroke. Smoking is also associated with increased risk for dementia and Alzheimer's disease, illnesses that have directly affected my own family. Maine is bringing in nearly $200 million a year in tobacco-related revenue. Restoring the funding cut to Maine's tobacco prevention and control program will result in a program funding level that is less than 5% of the state's tobacco-related revenue, yet will pay huge dividends in terms of lives and healthcare costs saved. The correlation between the COVID-19 pandemic and the increase in tobacco use has created an emergency situation whereby prevention and control are crucial. I hope you will join me in supporting this important legislation, and I thank you for your time.
Thank you for bringing that, that bill forward. We heard from the Tobacco Advisory Council report this morning.
Excellent.
Any questions? Representative Craven.
Thank you, Mr. Chair. Thank you, Representative, for bringing the bill forward. Do you know where the funds were that we lost from the Tobacco Cessation Fund was redirected to?
I don't, but I'm sure that there are folks who will be speaking after me who can probably answer that question for you. And if not, I'm happy to get that information for you.
Thanks.
I'm not seeing any other questions. So we'll thank the representative for being here to present this, and we'll begin to go to other folks who want to testify in support. That happens alphabetically, so that takes us to Allison Dragg. Welcome.
Thank you so much, Senator Claxton, Representative Meyer, and members of the Health and Human Service Committee. My name is Allison Perrin-Dragg, and I'm the Government Relations Director for the American Heart, American Stroke Association. We're the nation's oldest and largest voluntary organization dedicated to fighting heart disease and stroke. Our mission is to be a relentless force of a world of longer, healthier lives. We're supporting 1868. As you know, tobacco use is taking a devastating toll on our state. It kills more than 2,400 residents every year and costs Maine more than $811 million in healthcare costs, most of which is borne by our residents. It is a problem that starts with our children because nearly 90% of current smokers begin when they're 18 or younger. There's a clear need to act now and protect our kids from tobacco companies' efforts to addict them. Over 2,900 of our kids try their first cigarette each year, and one in 3 kids who get hooked on tobacco will die prematurely from it. It is well established that a comprehensive statewide tobacco prevention and cessation program prompts sharp reduction in smoking levels among both adults and kids by increasing the numbers of who quit or cut back and reducing the numbers who start or relapse. It is critical that we fund a tobacco prevention program to keep kids from smoking because the tobacco companies are spending huge sums promoting their deadly and addictive products. The state takes in $187.9 million annually in tobacco taxes and tobacco settlement payments, yet spends less than 4.5% of it on programs to prevent kids from smoking and help smokers quit. Tobacco companies, on the other hand, spend over $45.8 million each year on marketing and promotion, much of which influences kids to smoke. This means tobacco companies spend nearly $5.50 to market their products for every dollar that the state spends to reduce tobacco uses. You're in a unique position on this issue. We know the problem caused by tobacco, and we know that a comprehensive prevention and cessation programs are critical to be part of the solution. LD 1868 would use our clear revenue source to fund the solution. Investing in tobacco prevention is the right thing to do and the smart thing to do. It will save lives and money. I am appreciative of your time and attention today, and I'm happy to answer any questions.
Anybody have any questions? I don't see any, but thank you for taking time to be here. Excuse me. Next, we'll go to Hillary Schneider. Welcome.
Hi, sorry, I was having trouble getting off of mute. Good afternoon. Thank you, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. As you know, my name is Hillary Schneider. I'm the Regional Government Relations Director for the American Cancer Society Cancer Action Network. I submitted written testimony, which has more information, but I'm going to summarize the key points. On behalf of ACS Can, I'd like to thank you for the opportunity to provide testimony in support of LD 1868. As you heard, if passed, this bill would bring funding levels for Maine's tobacco program up to the level the legislature allocated for the program in FY21. This year alone, it's estimated that more than 10,000 Mainers will be diagnosed with cancer. Maine's cancer incidence rate is significantly higher than the national average, driven largely by higher than average incidence of tobacco-related cancers. Maine has the 6th highest rate of smoking-related cancer cases in the nation and the 11th highest rate of smoking-related cancer deaths. As you heard this morning, we are on the verge of rolling back decades of progress in reductions in youth tobacco use, largely driven by e-cigarette use. Here in Maine, 33% of high school students are current users of some form of tobacco product. According to a recent poll of likely voters conducted by Campaign for Tobacco-Free Kids, 3/4 of Maine voters are concerned, with nearly half very concerned, about young people in their community becoming addicted to tobacco products. Maine's adult smoking rate is also higher than the national average, highest of all the states in the Northeast. You may be surprised to learn that Maine's adult smoking rate is about the same as that of North Carolina and is higher than the rate in Georgia, Texas, Nevada, and Florida. Research shows that the more states spend on comprehensive tobacco control programs and the longer they invest, the greater the reductions in smoking and the quicker the impact. When appropriately funded, in accordance to US CDC recommendations, comprehensive programs are able to reduce tobacco use. Also, Maine's revenue forecasts are projecting significant surpluses. According to the latest revenue forecasting report, cigarette and other tobacco taxes are forecasted to be approximately $5.3 to $5.6 million higher each year. The report goes on to state that the most of the adjustment is from increased cigarette sales, and as a result, increased cigarette excise taxes above projections. You also just heard from Representative Cloutier that Maine's expected to collect nearly $200 million in annual tobacco revenues from both the settlement and tobacco taxes. Also, the latest revenue forecast report has settlement dollars coming in higher than projected. No matter when someone quits tobacco, there are large and immediate benefits. Perhaps these benefits are more important than ever, as you heard about the relation to tobacco use and increased disease risk from COVID. For these reasons, we urge your committee to vote in strong support of LD 1868 to restore the reduction in funding. Investments in this important program are investments that have been proven to result in substantial returns, both in terms of lives and dollars. And we think that the money from these surpluses would be related to tobacco would be a great way to fund this bill. Thank you.
Thank you for that. Are there any questions? I don't see any. Thank you for being here. Now we'll go to Mary Lou Warren.
Hi, thank you, Senator Claxton, Representative Meyer, and members of the Health and Human Service Committee. Thank you for the opportunity to testify on LD 1868, an act to restore funding to the state's tobacco prevention and control program. My name is Mary Lou Warren. I live in Winslow with my husband and two children, Carly and Jake, both student athletes in college. As a volunteer for the American Cancer Society Cancer Action Network, I support funding and legislation to protect our kids from the dangers of all tobacco products and nicotine addiction. I started advocating 4 years ago when I realized my 17-year-old son was vaping. I quickly learned how big tobacco companies targeted our youth with their relentless marketing campaigns, recruiting our kids to be the next generation of replacement smokers. I also discovered that Maine's Tobacco Prevention and Cessation Program had seen huge cuts in funding, and the tobacco settlement money was not being used for its recommended purpose. The damage was done, and big tobacco had made their way back in with an addictive nicotine product. When Jake was in elementary school, he would come home and tell me about how bad smoking was. I never thought he would use tobacco products, and I believe we, the adults, did our job. Instead, we let our guard down. E-cigarettes exploded in the schools. Excuse me. Flavors, sleek packaging, and targeted deceptive advertising are the marketing weapons used by the tobacco industry, attracting our kids to a lifetime of addiction. It became clear to me that the parents in the broader village that supports raising healthy children were blindsided. I was surprised to learn that the state had done nothing to educate Maine parents and children about the harms of these dangerous addictive products. Jake tried to assure me he had done his research and had this under control. He could stop anytime. I started to see a change in Jake. He was very agitated and angry. He complained of headaches, coughing, nosebleeds, trouble sleeping, and trouble concentrating. School bathrooms became known as vape rooms. Students had trouble getting through the day without a nicotine fix. When I tried to help my son quit, I found little information readily available to counter the messages he and his friends had been led to believe by the industry. I was encouraged in 2019 when legislation was passed to protect our kids and funding was restored. While this increase in funding has supported important work, we are far from done. Nicotine addiction is part of our family, and Jake has to battle with this every day. On most days, nicotine wins. Jake describes his addiction as a toxic, artificial love. He will say he can still remember his favorite flavor, a Red Bull flavor called Energetic Bull. It's been 4 years and he can still taste it every time he thinks about it. Addiction has changed his brain, and it's overwhelming to imagine this will never get easier. The bicentennial budget passed by the legislation last year included a $5 million year reduction in funding for the statewide tobacco prevention and treatment program. Meanwhile, the tobacco industry continues to target our kids, and our kids continue to use tobacco products at a disturbing high rate. In addition to the COVID-19 world, this has increased stress and anxiety for most people, including our youth and young adults. This is not the time to take our foot off the gas at protecting our kids from a potential lifetime of addiction and the related health effects. Please support LD 1868 to restore $5 million a year additional tobacco prevention and treatment funding. Thank you.
Thank you for bringing your testimony and your story.
It's an evolving story, and there's so many details that I'd be happy to share with you. There's so many positive things that are going on with Jake that this just seems like a cloud hanging over his head that's just constantly there. But
if you'd like to share in some greater detail, you can always submit written testimony, and
I will do that. Yes.
Committee would see it that way.
That sounds good.
Okay, great.
Happy to share.
Thank you for being here.
Thank you for having me.
Next, we'll go to Sarah Calder.
Good afternoon, Senator Claxton, Representative Meyer, and members of the committee. My name is Sarah Calder, and I am the Director of Government Affairs at Maine Health, and I'm here to also testify in support of LD 1868. Maine Health has long supported tobacco prevention and treatment programs for our patients, employees, and our communities. As you may know, in 2001, we established the Maine Center for Tobacco Independence, which you heard Deb Dietrich mention in her presentation to your committee this morning. And then in partnership with the Maine CDC, Maine Health also implements the Maine Quit Link, training for healthcare providers and other professionals throughout the state, and technical assistance regarding tobacco-free policies. Additionally, as part of Maine Prevention Services, CTI works with 16 community organizations to create tobacco and smoke-free environments across Maine and help Maine youth and young adults be tobacco-free. In October 2019, CTI received additional funds as part of the additional $5 million allocated by the 129th legislature for expanded tobacco prevention and control efforts. It's important to note that this coincided with Maine experiencing a 12% increase over the prior 2 years, which was 2017 to 2019, in use of electronic cigarette products amongst high school students, with close to half reporting ever using an electronic vaping product. So with that additional funding, CTI was able to respond to this alarming increase by implementing a youth quit vaping support service through the Truth Initiative, and that was called This Is Quitting. So This Is Quitting is a free and anonymous text messaging program from the Truth Initiative that's designed to help young people quit vaping. This program has seen 216 young people enroll, and the program acts as a call to action for the Maine CDC youth vaping prevention campaigns. And I just want to pause here because that seems like a small number. But in preparation for this hearing, I asked CTI leadership how often youth had reached out to the Maine Quit Link prior to the rolling out of This Is Quitting. And he said that in his almost 20 years with CTI, he's never had more than a handful of youth ever reach out for this service. So this really is making a difference. The additional funds also allowed for local prevention partners to engage with tobacco retailers on best practices and resources to prevent sales to youth. And then the funds also allowed for a more robust presence at the community level with additional staff added across the state. So I would just close by saying that at a time when almost 17% of adults in Maine are smokers and 33% of Maine high school students have reported a use of an electronic vape product in the past 30 days, we would urge you, this committee, the legislature, to fund the state tobacco prevention and treatment program at the US CDC recommended level of $15.9 million per year. And I would be happy to answer any questions that you have, and thank you for your time.
Thank you. Sarah, are there any questions? Sarah Calder? I don't see any.
Thank you.
Thank you for being here. I think we've heard from everybody who wants to testify in support of this bill. There's a hand up for somebody we have apparently missed. We have a couple of folks we'll bring in.
Good afternoon, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. My name is Ed Miller. I am from Hollowell and testifying today as a private citizen. I have 14 years of experience as the lead tobacco control person at the Maine CDC and almost 30 years experience as the lead tobacco policy person for the American Lung Association here in Maine. And I simply want to say that I support this legislation. I thank Representative Cloutier and the co-sponsors for bringing this bill forward and urge your support. Thank you very much.
Thank you for that testimony and for your years of service in that regard. Next, we'll go to Lance Bushy.
Hi, good afternoon, Chairs Claxton and Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services. My name is Lance Bushy, and I am the Assistant Vice President for State Public Policy with the American Lung Association. The Lung Association is the oldest voluntary public health association in the United States, representing the 37 million Americans living with lung disease, including over 258,000 Maine residents. I'm here today to offer our strong support for LD 1868 and thank Representative Cloutier for introducing the legislation. When it comes to tobacco, the evidence is clear that we need to continue to make a strong investment in our future. Tobacco use remains a major public health crisis in Maine, with nearly 2,400 Maine residents dying annually from tobacco-related illnesses, and it cost our state $800 million in healthcare costs every year, including $261.6 million in Medicaid spending. Despite smoking rates being at all-time low, Maine still has an adult and youth smoking rate higher than the national average. Even more alarming is progress we have made in reducing youth tobacco use has been evaporated by the rise in youth use of other tobacco products. The vaping epidemic has gripped Maine's youth and threatens our ability to have today's current middle and high school students be the first nicotine-free generation. Alarmingly, 1 in 3 high school students are using a tobacco product, and we must do all that we can to combat this dramatic increase in youth tobacco use that led the U.S. Surgeon General to call youth e-cigarette use an epidemic in 2018. The cornerstone of a successful effort in addressing tobacco addiction in our state is a well-funded tobacco prevention program that follows evidence-based strategies to help current tobacco users quit and prevent new users from beginning on the path to nicotine addiction. The US CDC recommends that our state fund the tobacco control program at $15.9 million. However, our program is only at 60% of the recommended level. This legislation would drastically improve funding for the program, restoring the $5 million cut that occurred last year. This is a small investment to ensure the health of our citizens, especially when, as noted, Maine takes in nearly $190 million annually in tobacco-related revenue. Just last week, the Lung Association released our 20th annual State of Tobacco Control report card that grades states on the effectiveness of their policy efforts to combat tobacco use. There were some bright spots on the report card from Maine: A's for strong smoke-free air protections and cessation coverage, but there was only one grade that dropped from 2021 to this year. We went from an A to a C for tobacco prevention program funding because of the cut to the budget last year. In the 2 decades that the Lung Association has released these grades, only one state has ever received a straight A report card, and that's Maine in 2006 and 2007. We know what needs to be done to address tobacco use among our residents. We have done it before and have been successful, and it's time to do it again. Strong support of 1868 will help us on that path. I thank you for your time.
Thank you for your testimony, Lance. I don't see any questions, so thank you again for being here. Next, we'll go to Deb Dietrich. Welcome back.
Thank you and good afternoon. Thank you and good afternoon, Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Deborah Dietrich and I live in Cumberland. I spent 21 years as the Senior Vice President for Community Health Improvement at Maine Health, where I co-founded, along with Ed Miller, I might add, the Center for Tobacco Independence. CTI has partnered with the Maine CDC for the past 2 decades to provide nationally recognized tobacco treatment and prevention services. Although I retired from Maine Health in 2019, I continued to work as a part-time consultant and volunteer board member. I'm here today as the chair of the Maine Tobacco Prevention and Control Advisory Council. I'm not going to belabor that because we were fortunate to make a presentation to this committee this morning. You have our report from 2020, hopefully in your home mailboxes. And there is much data that we have touched on today that is in that report. During my 20 plus years working for Maine Health, I frequently met with physicians and nurses and other healthcare and behavioral health providers who are on the front lines of providing providing health care and very involved in helping people quit smoking and using tobacco. Even before the pandemic started, they were challenged to spend the time needed to counsel patients about quitting. They always asked for help in the form of proven state-of-the-art cessation techniques and resources. And those services are provided free of charge to thousands of Maine's, have been provided free of charge to thousands of Maine citizens over the past 20 years. CTI does that with tobacco settlement dollars provided under a contractual agreement with the Maine CDC. As Lance mentioned last week, the American Lung Association issued its annual State of Tobacco report. Thankfully, our cessation services and cessation programs did get an A rating, but it's not only the cessation services that are counted there. It's also about the coverage under the Maine Care program, the funding, the coverage under the state employees health plan, and some other things. The point I want to make is that all of the components of the prevention and control program are interrelated, and we need all of them to be funded at the appropriate levels to make them successful. The Tobacco Council is fully in support of LD 1868. It is one of our priority measures for this year, and we ask for your support in supporting it as an ought to pass. And I'd be happy to answer any questions you might have.
Thank you for being here. I'm not seeing any questions. So I'll try again to make sure that there's nobody here who wants to testify on LD 1868 who hasn't been recognized to this point. I'm not seeing anybody. So we can conclude the public hearing on that because there's neither is there anybody for or neither for nor against. So are there questions of Sam in anticipation of a work session? I think we would count ourselves amongst the somewhat informed, and so you don't have any homework, Sam.
I have a question, actually.
Yes, Representative Craven.
So it was my understanding that we were going to have a reduction in the settlement, and I believe we are, but I know that Henry Schneider said this afternoon that we were going to have a better, a better settlement than what we had originally expected, and I would like to know how much and why the increase.
Okay. Thank you for that. Not seeing any other comments. At this point, we can proceed to consideration of LD 1693 if we can find the sponsor. Whom I'm not seeing. Am I missing something that somebody else is seeing?
I think so. I know he's got the link. Let me reach out.
Okay.
And just
Thank
to
you.
clarify, this is LD 1915, correct?
Yes,
Okay.
1915 will be the next bill being considered. And as I understand it, there are 1, 2, 3, 4 folks signed up at this point to speak for, and 1 against and 1 neither.
That's what I have as well, Senator, at this point.
Yeah.
I've reached out. Oh, he's here. Senator.
Yep.
He's on his way in.
Good afternoon, Representative Barry. Welcome. I understand you have a bill you'd like to introduce us to, LD 1915.
Good afternoon, Senator Claxton and Representative Meyer and members of the Committee on Health and Human Services. My name is Seth Berry. I represent House District 55, which is Bowdoin, Bodenham, most of Richmond, and beautiful Swan Island on the Kennebec. I apologize for my technology difficulties today. I think it was probably my fault, not the computers, but I'm very pleased to be with you here today to present LD 1915. Appreciate your patience. And the title is An Act to Improve Intensive Behavioral Health and Public Safety Case Management Services. I represent many state employees, and I've heard a lot of stories from many different departments. I'm aware, as are you, that retention and recruitment is a widespread concern across state government, and that wages are now 15% below, sadly, other New England states for comparable work and qualifications. But this problem, it is clear to me, is especially acute for our intensive case managers. Others will speak today to this, but ICMs, or intensive case managers, as you know, play a critical role in our behavioral health system. It is necessary, it is important, it is difficult, and it is at times dangerous work. So the bill would simply provide a stipend of $5 per hour for workers in the intensive case manager job classification, and a $1 per hour stipend for those ICMs who have or are working on a pertinent master's degree. As you know, stipends like these are already being provided to caseworkers within the Office of Child and Family Services in order to aid in recruitment and retention. And so LD 1915 would treat essentially the same problem with the same solution, treating intensive case managers the same as OCFS caseworkers in this regard. Ours is a constitutional and representative democracy, and I am firmly convinced, as I hope you are, that we in the legislative branch must retain and must exercise our independent authority to step in, just as we have done to protect child safety. Indeed, I would submit that if we in the legislative branch imagine that we have absolutely no independence in this respect, perhaps we have one less reason to be here at all. I value all of you. I value your independent judgment, and I hope you'll exercise it here today. As I told you in respect to another bill, at this time, my teenage son is able to make more per hour pumping gas than someone with a master's degree who is performing, in this case, some of the most crucial, complex, and challenging work on the planet. This is unacceptable. It is our right, and I would argue our obligation, to set things to rights for our ICMs. We have the means and the authority to respond to one of the most pressing needs of our day, simply by creating parity for ICMs with their OCFS counterparts. I hope we will not fail to do so. I thank all of you again, and I'm happy to try to answer any questions.
Are there any questions for Representative Berry? Mine was to ask where the $5 an hour would put the ICMs with respect to the average in New England.
That is a great question, and I will have to punt to someone that comes after me.
Okay. Yes, Representative Madigan.
Thank you, Mr. Chair. Thank you for being here, Representative Berry. How many ICMs are there in the state?
Gosh, that too is something that I need to understand better. I hope that it will be a question that the department can answer, and I'm sure will be a factor in the fiscal note.
And can we, I mean, I don't know whether you could give us this information or someone that follows you, kind of tell us, I mean, I know what an ICM is and what they have been in the past in the state. So I'm looking for information on what population those folks are working with now. My understanding is the ICMs are working with folks with mental health issues and in the jails, or kind of recently incarcerated. So if we could get more information on that, that would be great.
Thank you. I'll do my best to follow up and get back to the committee with more detail. But, as I mentioned, I do represent many state employees, and the stories that I hear are just incredible. It's called intensive case management for a reason. These are very special, high need populations. And I think for the sake of the individuals who are served, as well as for the rest of the public in many circumstances, we have to get this right. And we can't trust just anyone to come along and jump in and be called an ICM, because I think that would be a very dangerous approach. And unfortunately, I think increasingly that's what we're taking. So I hope that others can answer with more detail, but I will try to get back to you for the work session.
Thank you.
All right, I'm not seeing any other questions. So again, thank you, Representative Berry, for bringing this bill forward. Can you tell me how you settled on 5 as opposed to some other number?
Yeah, thank you very much, Senator Claxton, for that. And it's my understanding that would take the same approach, essentially create parity with our OCFS, their OCFF SF colleagues. And if I am wrong on that score, I'm sure someone later will point that out.
Yeah, that's a question that came up in another context about parity across classifications and how much classifications matched up. So, all right. Thank you again.
Thank you.
Is your hand still up? No, it isn't. Okay. So let's go to, did you have a question? Yes, Representative Madigan does have another question.
Representative Berry, when you just answered Senator Claxton's question, you're asking for parity with folks who in OCFS, would those be child welfare workers, like child protection workers, since there's an element of case management there as well?
That is exactly right. Thank you for that informative question. And yes, the child protective caseworkers do play a critically important role as well. I think the notion here is that these are somewhat analogous roles in terms of their intensity, in terms of their importance to society, and that it's appropriate that the stipend be a similarly proportioned additional step.
Thank you.
Thank you.
Okay, so now we're going to hear from Elijah Shear. Welcome.
Hello, thank you. Senator Claxton and distinguished members of HSS committee, and thank you for having me. I'm going to say that I am an intensive case manager and licensed clinical counselor in the state of Maine. I work as a social worker at Riverview Psychiatric Center. I have been here for 5.5 years. I have to say that I love my job. I'm one of those people that has a passion for this work. And I have been often find that it's somewhat a thankless job, but then I say that and I look around and I just was going through a folder and found, a stack of cards of thank you notes. I get calls from my patients who I discharge to the community and work with while they're here at the hospital. I also will occasionally get a phone call from someone just to say hi, just, let you know that things are good and thanks so much. We also get a lot of really challenging calls as well. I don't really have a speech prepared. It was sort of a last minute. I wasn't really aware that this hearing was going on. So I just want to put out sort of a broader overview of my perspective on this legislation or proposal. I heard a question, is this for how many intensive case managers are there? Where are they and what do they do? So I'm estimating there's approximately 30 of us working for the state, and this proposal is for the intensive case managers who work with the DOC in the jails, and RPC and DDPC is my understanding. And a little bit about what we do. We are the immediate comprehensive case management services. We follow up and responsive interventions to assigned group of the most problematic high risk mental health clients in support of their integration into the local community. We're basically the liaison here at Riverview and at DDPC. We're the liaison between the patient, their treatment team, outpatient providers, medical providers, the court systems, and the private sector, and all of the community behavioral health and housing agencies. So we are kind of the directors and the liaison to help facilitate transition and reintegration into the community. We work closely with our patients. And I remember when I was hired about, 5.5 years ago, that a proposal I don't really know exactly what it was because I was very new, but it had just gone through the legislature asking for I believe it was a $2 to $3 raise for DHS or Riverview staff anyway, who were
30 seconds, please.
Oh, sorry, direct care providers. And it was approved for everyone but the case managers. And I found that really confusing when my office is on the unit. And within 6 weeks of being at Riverview, I was assaulted pretty severely by a patient. And I spend so much time with these patients. So I find that, in the current situation, our top pay at the 8th level, at step 8 is comparable to the community's entry level position. And I also have a master's degree, and I'm finding it really hard despite how much I love my work, I'm finding it hard to make ends meet. So I am speaking in support of this bill. Thank you so much.
Thank you for your testimony. Representative Madigan, is your hand up? No, okay. I see a question from Representative Lemelin.
Thank you, Senator. I'm curious what these wages are you're talking about. Is this an hourly wage or a salary? Number one. And number two, what is the entry wage level and what's the level for level 8 that you're talking about?
So entry level for a grade 23 hourly, and it is a hourly entry level with the state is $43,000 a year. And step 8 is, and that's 8 years, steps up to 58,531. And I have done some comparison. Right now, there are a lot of private agencies who also are counselors are in high demand right now. So there are entry level pay starts over $60,000 in the community with a $10,000 sign-on basis.
Okay, thank you. I have a question for Representative Barry. I don't mean any disrespect here, but I don't know anybody that pumps gas for $43,000 a year. So am I missing something? I'm just confused, sir.
Representative Barry, do you want to address your son's hourly wage?
I didn't realize that this is how the public hearings work in HHS, but I'm happy to take a stab at that. So is it my understanding, could you clarify for me, Mr. Chair, did we just hear that the very lowest pay for ICMs is $43,000 per year?
That's what I heard.
Great. So, and is that with a master's degree?
I didn't hear that.
Got it. So the short answer is yes. In my son's case, that is in fact what he was able to make as a teenager, pumping gas. He was well over that amount this past summer.
On an annualized basis.
That's right. Yeah.
Representative Zager, thank you for that. Representative Berry.
Thank you, Mr. Chair. I guess a technical question is, the bill seems to be written as if there's, it's an hourly, these are hourly wages, but what Ms. Scheer just quoted was a salary, I think, or is that just on an assumption of a certain number of hours per year, per week that's worked? And so what is the, is this a salaried position or are they hourly?
I can answer that question. The salaries are based on a 40-hour work week.
Okay, thank you. That clarifies it.
There's no overtime.
Right. Okay. And yes, Representative Berry, we did go slightly out of order there because there was a late question coming in from one of the committee members. Next, we can hear from James Bailey.
Good afternoon, Senator Claxton, Representative Meyer, members of the Health and Human Services Committee. Thank you for allowing me to testify in support of LD 1915. I have submitted written testimony that I'll let speak for itself. I'll address a few things that I've heard so far. One is who we work with. Across the board, ICMs work with how I would summarize the people at the worst points in their life, whether it's children being taken away from families, adults that have been told they can no longer make decisions for themselves or about their finances, people in jail and in prisons, or people psychiatrically hospitalized. I'm a ICM at Dorothea Dick Psychiatric Center. I've been here for about 4.5 years. I've worked with insanity acquittees, people who have committed arson, murder, aggravated assault, sexual crimes, people being accused of multiple crimes and looking at years in prison. I work with one gentleman who has been hospitalized for more than 5 years contiguously because of his difficulties. Where you will find the ICMs is in all the bottlenecks that I'm sure you get in many of your reports. Emergency departments, jails, hospitals, group homes, psychiatric providers, ACT services. ICMs are going to be the people in between. We're the ones that a doctor says, I want a patient discharging to have this. Nurses say, I want them to have this. Pharmacists, recreational therapists, occupational therapists, clinical social workers say, these are all the things we want the patient to have when they leave the hospital so they don't come back. Our job is to find those things, make them happen. So when the patient can get out of the hospital, they can stay out of the hospital, and we can have room for the next person in jail, the next person in an emergency department. And further, as to why we are before the legislature and not in negotiations. We have been in negotiations the past 3 cycles. We've asked to address this disparity, and the executive branch has declined to address it. Knowing that there's a 15% across the board disparity with workers in the rest of New England, and those numbers are based pre-pandemic, the executive branch hasn't dealt with it. So we're going to the legislative branch, which represents us, to help us overcome this disparity. Thank you.
Thank you for your testimony. Are there any questions of Mr. Bailey? I'm not seeing any, so thank you for being here and thank you for the work you do.
You're welcome.
Next, we'll go to Bobby Bard. When you unmute, we'd like to hear from you. Bobby Bard, we're ready to hear from you if you want to unmute. I see your hand is up. If you'll unmute, we can communicate. We're ready for your testimony. Now we should be able to hear you. It's your turn, Bobby Bard, when you're ready. This is one of our predetermined technical glitches that we encounter on a daily basis.
You want to move on to the next person, and perhaps Bobby Bard will rectify the technical difficulties?
I had a request to do it in a different sequence, and I was trying to respect that request, but I think we're going to go to Jeff McCabe. I tried.
Thank you, Senator Claxton. Thank you, Representative Meyer, members of the Health and Human Services Committee. My name is Jeff McCabe, Director of Politics and Legislation for the Maine Service Employees Association, Local 1989. We are a labor union representing 13,000 Maine workers, including the workers who serve as the intensive case managers for Maine Department of Health and Human Services. I'm going to stray a little bit away from my remarks because I know that folks will be able to read those, follow the links that are in there. But, I did want to say that this is clearly difficult and dangerous work. And I think that as we continue to talk about the safety net that exists here in Maine, as you are the committee of jurisdiction over these positions, as you as a committee sort of struggle with how to address crisis situations here in the state of Maine, as you work on issues of diversion, as it relates to corrections, as it relates to our state hospitals, I just want you to think about the workforce and make sure that we have the workforce, not only that the state needs, but that you as legislators and the committee of jurisdiction really want to see in place. I watched the committee the other day struggle with how to get involved or not get involved around the issue of stipends and wages. And I think it's important to sort of, take a look at where we are at as a state, where we have vacancies, where we're not able to retain people, and to really think about your role in that entire process. And I did appreciate the comments that the entire committee made the other day. I was impressed by, the deliberation that the committee had over stipends. And I just wanted to hit on some key points. Stipends can come in really three ways. They can come through the bargaining process. They can come from the legislature. They can come from recruitment and retention committees. Those recruitment and retention committees are often pulled together by the state. Sometimes they're requested by members of a bargaining unit, in this case, MSCA. But at the end of the day, it requires sort of a willing partner in the administration, in the state, to sort of sit down and have those tough conversations. You've heard a little bit about the compensation study, and I just wanted to hit on some key points that for the last three administrations, the state has not addressed our compensation system. We have a compensation system that is probably, 10 plus years behind. So when you hear the state come and talk about a 4% raise, that's just a 4% raise for 1 year. That has nothing to do with sort of the 15% that these positions are already behind in comparison to, state and in regional sort of comparisons. So that's a real challenge. We're just operating at this deficit. We're not catching up. I think that, as we talk about wages, I've heard some of the committee members say that, wages are probably not the solution. And while
30 seconds, please.
Sure thing. As well as, wages might not be the only issue. You can't expect these people to just continue to be so overworked and understaffed and overpaid at the same time. It's just creating sort of disastrous conditions. So with that, I did stray from my testimony. I'm happy to take more questions, and I'm happy to answer questions about the number of ICMs as well as other questions you might have.
So the question was asked earlier about the number of ICMs in state employment. Do you have a number for that?
Yeah, so when we looked quickly, when the question came up about 15 minutes ago, it looked like we show in our database that we have probably 36 positions that fall within our representational sort of coverage. Whether or not all of those are filled or not, I would have to get that answer for you and sort of circle back. Like similar positions, sometimes we have folks that are out on leave due to stresses associated with the job and other issues. But we believe it to be, 35, 36 positions. And I think the state could probably answer quicker how many of those are filled as well. So thanks for that question.
Thank you. Are there other questions of Jeff McCabe? Yes, Representative Stover.
It would be helpful probably for the work session to look at the ICM's classification, the child protective caseworker classification, adult protective caseworker classifications, I think it's just for a point of clarification. However, that being said, I'd also just like to go on the record saying I've worked with all three of these groups of people, and I want to speak specifically to the ICMs because I was fortunate once in my life in my career to help with the startup of this program. And I had probably as many ICMs in Region 2, which is the 9 middle counties of the state for adult mental health as we have in the whole state now. And I had the fortune of working with some of the finest individuals I've ever known, many of which stepped out of the state hospital to come work in the community. And they did things that nobody else ever did. And when I say nobody, we had people who lived off the grid a mile into the woods. And I had 2 case managers that would go a mile into the woods to bring groceries or to bring medicine or to do other things. And we had a medical director who would follow them wherever they went. We had people who were at the scenes of serious sentinel events in the community, including murders, homicides. And they did things at a time when nobody else was available. Now they've been dispersed a little differently, but it's no less cutting edge. They are people who every day go out there, whether they're inside an institution or not, and they do things that some of us can't even imagine calling our jobs on a daily basis. So I'm not comparing their salaries to anybody else. I'm just saying we should take a look at both the classification for comparative sake, for the comparison of looking at other people who also do incredibly dangerous work. But I don't want us to get lost in a figure that it's placing a dollar value on the work that they do, because I know that they do things every day that save people's lives and sometimes save our own in a public safety perspective. And they care compassionately, and they're probably the most loyal group of people I ever worked with. And I'll stop there. Thank you.
Thank you, Representative Stover. Representative Madigan?
Yeah, I just want to, I'm going to agree with Representative Stover. I've worked with a number of ICMs in my career, and they did go places and do things that no one else would do. And I realize I have to put this in the form of a question. So what would be really helpful for the work session is if we could get some numbers as far as injuries on the job, dangerous situations on the job, things like that. That would indicate the severity of situations they're dealing with and the acuity of people they're dealing with. That would be really helpful.
Thank you.
Thank you for that, Representative. And I think we can put those together. And I imagine probably the ICMs, it'll be easier for them to do that in a manner that's not directly associated with an individual, but done in a manner that's anonymous.
Very good. Any other questions, Mr. McCabe? I don't see any. So let's try again to see if Bobby Bard can join us. Bobby, if you're there and you unmute, we should be able to hear you. So I will note that there has been written testimony submitted by Bobby Bard. So I think we're going to have to go with that. And before we go on, is there anybody else here who wants to testify in support of this bill? Please put your hand up. I'm not seeing anybody. So there is testimony against. So I'd invite Brina Bissell to join us. And we'll hear from her. And then the only other speaker I know of is Mallory Shaughnessy. So we'll invite her into the room too. The virtual room. Welcome, Brina Bissell. Thank you for being here.
Thank you. Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. I am Brina Bissell, Director of the Bureau of Human Resources. LD 1915 seeks to provide funding for 2 different stipends for the recruitment and retention of intensive case managers, or ICMs, at the Department of Health and Human Services, including those at Riverview and Dorothea Dix Psychiatric Center. $1 per wage hour for ICMs holding or obtaining relevant master's degree, and $5 per wage hour for all ICMs. We certainly understand the sponsor's good intent to affect the compensation of the hardworking and dedicated intensive case managers through legislation. However, the Bureau of Human Resources fundamentally opposes increasing pay through legislation and instead recommends the avenues that already exist to conduct analytical review and make appropriate determinations with regard to compensation for all employees. I'd like to briefly highlight these processes and again refer you to the written testimony for more details. First, collective bargaining is an appropriate forum for negotiating wage increases and other benefits, including educational stipends. The written testimony provides details on the administration's generous wage increases and improved benefits for state employees. Next, the state is in the midst of a recently negotiated classification and compensation study, which will include a review of classifications at the Department of Health and Human Services. The reclassification process is in place to evaluate proper classification of positions and determine the correct associated pay for the requisite job. And there is statutory language which provides the process and criteria for recruitment and retention stipends. Following these established procedures allows the state as an employer to thoroughly review requests for pay increases in an organized manner consistent with procedures, ensuring a comprehensive overall view of all related state positions. Increasing pay through legislation contributes to pay inequities across state government. 2 examples of pay inequity are pay compression and pay imbalance. With regard to pay compression, in this instance, intensive case managers are at salary grade 23 on the professional and technical salary schedule. As a quick aside, I will say that child protective caseworkers are grade 22 on the ProTech salary schedule. The majority of the existing ICMs are at step 8, which is $28.14 per hour when you break it into an hourly rate. A number of ICMs report to social service program specialist 2s who are at salary grade 25 on the supervisory services salary schedule, for which step 8 is $33.01 per hour if you break it into an hourly rate. Affording the ICMs a $5 per hour increase would result in their salary surpassing these supervisors' pay. Legislatively increasing pay for ICMs also creates a pay imbalance with other classifications deemed through the Hay methodology utilized in the reclassification process to be comparable in scope and associated pay. Through this bill, grade 23 ICMs would get a salary increase that is not afforded to other grade 23 positions on the professional and technical salary schedule. I would also like to note that of the 12 ICM positions at Riverview and 9 positions at Dorothea Dix Psychiatric Center, all of them are filled There are no vacancies. While there are 8 vacant positions of the 16 ICMs on the behavioral health side, 5 of these vacant positions are newly created. They're brand new positions, and there are job offers in process right now for 3 of the 5. And the remaining 3 positions that are vacant are by long-term employees leaving, one by retirement and another by promotion. Again, while we certainly understand the good intentions of this bill, and we respect and support our hardworking and very dedicated employees, we suggest utilizing already established procedures rather than adjusting pay through this bill. I thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you for that. As I was looking at the list, I didn't see any written testimony yet. It may be taking a while to get through the portal, but you will be submitting something written.
My understanding was it was submitted, so I
Okay.
apologize that you don't
No,
have.
that's okay. I just want to make sure it was submitted. Representative Madigan?
Thank you, Mr. Chair. Thank you, Ms. Bissell, for being here. I have a couple questions. One is you referenced the HAY system, and I'm wondering if you could speak more about that. It sounds like it's a methodology or something that you use to classify jobs. I mean, I'd like to know like how old that is, how long have you guys been using that? And I just want to know, have you or your division ever supported any sort of stipends that the legislature has, enacted before?
Have we, I'm sorry, and can I ask for clarification on that?
Sure. I mean, have you ever supported kind of stipends before? Because that's something we've discussed in this committee before.
Right, as far as testifying in favor at the legislature, or so I'll back up a little bit. And
sure.
The HAY methodology, the first part of your question, has been the methodology that's been used for quite some time in state government. I'm not exactly sure how long, but it is a well-established methodology for determining classification, and then you score different elements of the depth and breadth and scope of job duties so that you put comparable breadth and depth and scope on a similar classification grade. And then we negotiate pay usually, but that information is used to determine which grade they go to in the classification plan. And then it affects the associated pay. As far as the Bureau of Human Resources supporting any kind of stipends, we negotiate them regularly through negotiations. I myself was the chief negotiator for the state for 10 years, or a negotiator for the state for 10 years, and have negotiated many stipends for educational stipends and other stipends. And I've also been very involved, and the Bureau continues to be involved in the statutory recruitment and retention stipends. There is statutory requirements on how you would determine if a group is eligible for recruitment and retention stipend, but usually you have a lot of vacancies and you show that you can't fill your position. Like that is a requirement for recruitment and retention. And I'm not seeing that here when I did my work to prepare for testimony today, where all the positions are filled except the newly created ones and a few that just vacated recently. And so hopefully I answered. I don't recall I don't recall testifying in favor of a legislative stipend because we have these other avenues that I'm very familiar with and have used over the years.
All right, thank you.
You're welcome.
Representative Zager?
Thank you, Mr. Chair. Ms. Bissell, thank you very much for your service to the state. I know it's a difficult job that you and other state employees have. I'm not an expert in labor negotiations like you, and I'm just trying to understand what do you think some of the factors might be to explain what we've heard in testimony and have seen written for this delta, the difference between what Maine state employees get paid on average and what comparable other states employees get paid?
So as part of the classification and compensation study that we're currently immersed in, The consultant Siegel did do a wage study. This was done, I want to say in the summer of 2020. And there is information that was gathered on that. It's not information about every job in state government. There were only benchmark positions that were reviewed and compared across state government. And I would have to double check, but I do not believe that ICM was one of them. So I don't know where the 15% is coming from. I'm not sure where that's coming from. And that study, which was put out a while back, did show that there was an average of 15%, but in testimony that I provided previously, there are a lot of classifications that are well over the market. There were some right at Riverview that are 122% of market. So it's unfair to just make the assumption that every position is 15% below. It's also unfair to use that 15% number when, since that information came out, there has been a 3% increase, a 4% increase, a 2% increase, and we're getting another 4% increase in July. So if that's where the 15% is coming from, if it's coming from that study that was done before all the wage increases, and a study that was done that just had an average 15%, then I'm not sure it's accurate. But I don't know for certain, and it may be that some of the people that testified had other information. I did hear one of our dedicated employees talk about jobs in the outside having starting pay that was higher. That does happen. I mean, we see that. We are proud of the benefits we offer in state government. Employees start with 3 weeks of vacation. They have a retirement. They have paid parental leave. And those are a lot of benefits you don't see elsewhere in Maine. And that's it.
Mr. Chair, follow up.
Please.
Thank you. I've read the Siegel study, and to your point, like that, it doesn't include every position in Maine. Obviously, that's impractical. I'm just trying to understand, to the extent that it did document a difference on many positions, not every position, but in many positions, and that the mean was 15%. And they actually looked at like the high, low, medium, and high, but it was like 85%, 83%, 87%. So that's pretty standard deviation. I'm just trying to understand the dynamics that you've been privy to that has yielded that aggregate result that might be relevant to this bill that we're considering. Why are the wages lower in Maine, in other words?
They're not lower in every case, but so it's hard for me to answer that question. I think there have been periods of time where there weren't salary increases. That hasn't been the case with this administration, but that has happened. And so when that happens, it can put you below, set you back. So we have worked really hard to get the wages improved and up, and have been very generous through negotiated wage increases.
And it does appear that things are on the move in that regard. Well, I appreciate you're helping us understand everything that's involved here.
Thank you.
Representative Stover?
Sure. I just want to thank you, Ms. Bissell, for those answers. This is difficult to understand. As I understand, the ICMs are range 23s, and I assume that's been the way, that's always been the way. So I'm just curious, given their current function, is there ever a periodic opportunity to do some sort of audit of their positions to see if they're still functioning at that same range of 23, or are they exceeding it? I know there's exceptions for where they start based on some age, some education, and if they've been in the state system and if they transfer, but this range 23, has there been I know inflation's a different factor, but has there been any sort of desk audit done of their positions to see if where they, the work that they do is comparable to the compensation they're getting from an audit perspective?
Thank you for that question, Representative Stover. I do not know off the top of my head when the last review would have been for that classification. I can certainly find out. Employees have the right at any time to file a functional job analysis to have a review done for their position. And so that is a process that exists and is available to all employees.
Thank you very much.
Thank you.
Representative Meyer?
Thank you, Mr. Chair. Thank you, Ms. Bissell, for being here. What's the turnover rate among ICMs?
I don't have it specifically. I looked into the positions that were newly hired, and mostly what I could see was they were replacing people who had retired or promoted. Not in every case, but I did see that. I also was able to see that, like I mentioned, the majority of them were at step 8. I think there was only one person that was at step 1. When I looked at RPC and DDPC, it looked like at least half or more than half had been in the job over 5 years. And it looks like the behavioral health side just added a bunch of new positions. So with those vacancies that they have. But that was just my quick look at data just recently. So there's probably more information out there.
Thanks.
Any other questions? Your hand's still up, Representative Stover. Ms. Bissell, well, when you mentioned pay changes of 3%, 4%, 2%, and 4%, over what period of time?
That's just in this administration. So I believe the first raise was September or October of 2019.
Okay, thank you very much. All right, are there any other questions? I don't see any. I think we have, I see Bobby Bard is back again, and let's see if we can get this to happen this time. So we should be able to hear you now, Bobby.
Can you hear me?
There we go.
I'm very sorry. Computer
We can hear you and see you.
I switched to a phone. Senator Claxton, Representative Meyer, and the members of the committee, my name is Bobby Bard. For anyone that doesn't know, there are 4 different types of ICMs. There are inpatient, outpatient, jail ICMs, and a new team called the Justice Team. There are a little over 40 ICM in total. As for me, I work as an ICM at the outpatient team. The team works with around 60 clients that have been found not criminally responsible NCR by reason of insanity as a result of mental disease or disability. They fall under the care of the custody of the commissioner in DHHS. Out of the 59 NCR clients, 17 have killed 1 or more people, and an additional 27 clients have committed violent offenses, including assault, aggravated assault, elevated aggravated assault, and attempted murder. The remaining 15 clients have committed child molestation, child pornography, visual child aggression, criminal threatening, terrorizing, stalking, criminal mischief, and/or arson. We are tasked with keeping the clients and society safe. The team members monitor clients' compliance with their court orders, support development of client skills and independence, and assist clients' symptoms and safety. As part of these responsibilities, it is the team's duty to observe and supervise clients while they're in their homes and in the community, often while working alone and without nearby backup. This job is not for the faint of heart and can be dangerous at times. I personally was on the team when a client was shot 3 times in our lobby, and I have been assaulted. Last year, I was tasked to drive well over an hour to pick up a client that had an increase in paranoia and was refusing medication changes. A peer and I went to get this client to transport him back to RPC. This client is capital. He is in the NCR system because he killed someone. As an ICM, we had no backup except for each other in 911. I'm happy to say that this client went back into the hospital without incident. But as ICMs, we never know what will happen in these types of circumstances. A few years ago, Child Protective Services was given a $5 stipend, and now ICMs are asking to be made whole with that. Our pay grade is pay grade 23. Child Protective Services is pay grade 22. So when we're talking about disparities, Child Protective Services now has an increase of $3 more per hour than what we make. There is no denying that Child Protective Services is a very important service, but I hope after that you hear what we do, you will realize that intensive case managers is just as important, but in different ways. I urge you to support this bill, LD 1915, and show all ICMs that the good work that we do is noticed and appreciated. Thank you for your time and consideration, and I'm here to answer any questions you might have.
Thank you for that information, and thanks for hanging in there so that you could testify.
Thank you for allowing me to.
I'm not seeing any questions from the committee. So we have one other person that I'm aware of to hear from, and that would be somebody speaking neither for nor against, and that would be Mallory Shaughnessy. Welcome again.
Hi, thank you for welcoming me once more to give testimony in front of the committee. Senator Nat Claxton and Representative Meyer and members of the Committee on Health and Human Services. My name is Mallory Shaughnessy. I'm a resident of Westbrook, and I'm the Executive Director of the Alliance for Addiction and Mental Health Services. Excuse me if I'm a little froggy. My throat is still recovering from COVID, and some days are better than others. On behalf of the 35 members of the Alliance, I am here to speak neither for nor against LD 1915, but to urge that any action taken on this legislation for intensive case managers or ICMs be considered also for those in the private community-based sector doing intensive case management work and working within other much needed mental health services such as ACT and many mental health residential settings. The Alliance supports all of those working within the behavioral health field, receiving a living wage and an adequate benefit package commensurate to the critical service they provide, as well as the training and expertise they bring to this work. We also laud the work that the ICMs do and agree we need probably twice the amount that we have currently to meet the needs that are out there. And to somebody's testimony earlier, I'm not sure who's offering $60,000 and $5,000 bonuses, because that is not the safety net main care providers that are in the Alliance. And we do have a turnover rate of around 40 to 50%. But the state of Maine has shown it believes case management services are critical. I believe that many people have referenced the child protective caseworkers and the increase that they received. One of the things that we saw in the field was we lost many workers to the state when that happened. This type of pay and benefit disparity is not only fundamentally unfair, but it creates this unhealthy competition with the private sector that is trying to provide the services within the safety net. There's been a lot of discussion about the crisis in the essential workforce within healthcare and especially within behavioral health field, but we need to lift all the workers up together and provide a livable wage and a sufficient benefit that they can all have it as a full-time job and not need extra benefits through food stamps or supplemental other payments, which many people doing work in this field are eligible for. We need to ensure that Mainers struggling with behavioral health conditions have similar access to the services they need, no matter where they are getting them from. So I would just thank you for your consideration for these thoughts and concerns, and know that we do wholeheartedly believe that folks doing this work should be being paid and getting the benefits that they deserve. And with that, I will end and answer any questions that you may have of me.
Thank you for that testimony. Are there any questions of Mallory? I'm not seeing any. Okay.
Thank you.
So if there's somebody else who'd like to testify in the attendee list, it looks like everybody's already been in and done their thing. So I think what we'll do is close the public hearing consideration of LD 1915 and see what questions we want to direct to Sam for the work session. Yes, Representative Madigan.
Yeah, I just would like more information about that, like hay methodology. Is it used in other states? How long have we been using it? I mean, it looks like something we use to see whether jobs are similar to one another. So anything you can find out about that, that would be great.
You want the one pager version or the 12?
One pager would be good. I don't need a complete
Okay.
journal article or anything.
Thank you. Representative Perry?
Yeah, I am really trying to get my head around a lot of this, and the more we get, the more uncomfortable I get. And there was a mention that a classification 23 earned more than a classification 24 or something like that. I want to know where the disparities are. And I have a feeling some of these disparities have been created by us. So I don't know if there's a way to find that, but I think we need to have a better understanding of what we're affecting, who we're affecting. Are we going to continue to have these every year, trying to make up for things we've already done? And so I would really like to see something that would give us a picture.
If we could ask Ms. Bissell about how much she's had to change based on what we've done. Representative Stover?
Along the same lines as Representative Perry, I think it would be helpful to look at the classifications I said earlier of a child protective worker, adult protective worker, and ICM, and perhaps the functional job analysis, which is a printed sheet, and/or job description, which are usually two different things, for the classification of an ICM at range 23. Thank you.
You all set with that, Sam? Okay. And Representative Lemelin?
Thank you, Senator. I heard grade 22 was the child protective worker and grade 23 is what we're looking at. Is that correct? And I see Representative Barry nodding his head yes. So grade 22 is lower pay than grade 23. Is that correct? The higher the grade, the higher the pay? Does anybody know?
Yes, that's correct.
That is correct. Okay. So the child protective worker was, I think what they said, I just want to make sure I have this clear. And if I don't, if you get this for us, Sam, the child protective worker makes $3 an hour on starting less than the position, the ICM that we're talking about. Could you just get that for me, Sam, please, so I can see the difference on paper?
Sure, and I think that they were referencing some disparities based on the stipends for the range 22 workers, but I will clarify all of that and get that to you, Representative.
Thank you. And if you can get me some clarification on what type of stipends are available for one and not the other, I would greatly appreciate that.
Any other questions for Sam for the work session? I don't see any. Okay, so that'll conclude our consideration of that bill and our preparation for the work session. Thank you, Representative Barry, for bringing it forward.
Thank you. Great discussion. Take care.
Take care. Is there any other business, Sam, that you would like us to conduct before we take a break? Until, looks like it would be 9 o'clock tomorrow morning for our public hearing. We only have two bills to deal with. So we'll see how that plays out. I will be turning the chair over for the morning to Representative Meyer while I finish up some training that I've been slow to get around to because none of the other dates worked. So I won't be here in the morning. Although at 9, I could be the senator if Senator Baldacci's tied up or Senator Moore. So I will leave it to Representative Meyer to let me know if I need to jump on the call to be the token senator. And then I'll join you as soon as my training is done.
Senator, I have that training also.
Yeah, 9:30. Yep.
Me too. I thought it was 9 to 10:30.
9 to 10:30. That's right.
Yeah,
yep.
I have it too.
I think I'm in it too, actually.
So
I'm sure that we have a quorum.
Well, I was going to say, so I think what we ought to do is, I think we may have to jump over some of us.
I can, if we're lacking, I will reach out. I believe Sam has his hand up.
Yes, Sam.
I just wanted to note that I did email out amendments for both of the bills that are being heard tomorrow. Both of the sponsors have offered amendments, and I just mentioned it because they're a bit technical. So it might help if you have a moment to look at those beforehand.
Some evening reading. All right. Yeah. So Representative Meyer, you'll have to feel comfortable just doing all points bulletin, and we may need to tell our instructor at 9 o'clock that we'll be back in 5 minutes after we launch the meeting.
Sure thing.
How will we know if a weather-related cancellation happens? It'll be on TV.
You'll get a posting.
If we have electricity. I guess either way, I wouldn't show up.
Yeah, right. Yeah, you won't be here. So I have no idea where that stands. It's only 42 degrees right now here, so it hasn't started to drop.
Let's see what the morning brings.
Tomorrow.
Yeah. I did see on the notice as a reminder about the anti-harassment training that something was said about the last scheduled training session. So I'm going to make a query about whether there might be a training session for delinquents at some later date that would be less intrusive on the committee's work, because we don't meet on Monday. There's a whole bunch of time then. So I'll see what I can do, but I make no promises. Anything else? It's been an interesting day, and tomorrow will be interesting too. All right. Pleasure working with you all. Thank you. And we'll see you. Some of us will be here at 9, some of us at 10:30, and some of us later than that. Have a good evening and stay safe.